All righty, let's do this thing. So the slides that I'm going to cover today are the high yield points for your MSK exam, upcoming MSK exam. And it does say weeks 1 and 2, but I'm going to cover the entirety of the module as best as I can. Of course, a good chunk of your anatomy is what is going to be tested more heavily. So I want you guys to focus in on that and not spend too much time worrying about the material that's going to come at you this week. I believe it's the tail end of this module that you guys are going to get essentially a little bit of the molecular and the genetic components of this. I'm going to cover those as well. So don't worry, I'm just prepping you guys up for when you guys walk into this week's material, okay? Of course, the high yield anatomy does come from weeks 1, 2, and 3, and then the rest of it just tends to be the little bit of molecular genetic information that you need to make your way through the rest of the material. Okay, so let's get the ball rolling. My name is Kishore. I am a term 4 medical student, and co-facilitating with me is Sayesha. Feel free to introduce yourself.
Nothing to introduce. I'm in the same boat as, or we were in the same boat as you guys. Term 1. Honestly, you will survive. Like, that's not even like a question. You guys will do fine. Just obviously Kishore is doing a great job with the reviews. So just pay attention to the high yields and you guys should be good to go.
All right. I love the words of confidence. Let's get this thing done. Okay. So as always, we run, here's the TPLG, a group of us actually run it. So it's a fantastic page. I'm putting the QR code for the actual Facebook group, and there you can get access to our Facebook and Google Drives, and where we post all of our review materials, as well as content that we personally use when we were going through this module, as well as other terms and modules, okay? Feel free to scan it. It's also included in your guys' slides, so use it as you will. I do have a bunch of practice questions for you guys in these documents. A big shout out to my friends Brady and Lindsay for providing the scaffold for this review. A lot of their slides were incorporated into mine, and then I, of course, built on them. So feel free to download and use these slides for your own edification. Okay, so important thing, I hope you guys have been doing your grades questions. It is essential. Whenever I went through this module and I gave advice to folks, I always tell them, make sure you guys download the eLink ebook app. And that is a fantastic app that can test your knowledge constantly. And you don't have to like flip through the book of the Grey's Anatomy review to do your questions, because it gives you direct feedback right off the bat. So I will try to link it after the review to this recording so that you guys can download it and use it. There's a QR code associated with your book that you can scan to unlock the online version for free. So it's fantastic. I highly recommend you have those downloaded because they will help you in CPR as well as other terms. And personally, myself and Sayesha have all used that eLink app because it's hella helpful. Okay. A lot of the high yields are coming from the grays in terms of concept wise. So make sure you guys do those questions. I'm begging you guys. It is definitely tested. It is worth doing those questions. Okay. So let's get the ball rolling. Now, the first thing to note is just setting up the general scaffold of what makes our axial system. Okay. We have 7 cervical vertebrae, 12 thoracic, 5 lumbars, and the sacrum and the coccyx are fused, okay? Now, the important thing to note is that each of the properties of said vertebra has its own unique shape that you can use to identify it. Obviously, you're not asked to take apart a human body to check one of the vertebrae. You can actually palpate it and assess for if you're in like the thoracic region versus the lumbar, and you can do a lot of things with this, okay? Now, the important thing to note is, of course, they like to test the embryological origin of a lot of things. So in terms of the nucleus pulposus, what is the embryological origin of that? Feel free to drop it in the chat because they love asking you a question about this. Notochord, high yield, guys. Notochord is absolutely correct. It's one of the unique things. Annulus fibrosis comes from the mesoderm, right? Whereas the nucleus pulposus, you would think, like, since it's providing structural support and giving a cushion-like system to your vertebra, you're going to be like, well, it has to come from mesoderm because it's the means by which everything gets held up. You'd think it'd be mesoderm, but it's actually notochord in origin. So nucleus pulposus, notochord. Okay, high yield. Keep that in mind. They love asking questions about this. So let's put a question on the table. I'll give you guys about 30 seconds to kind of look through, and then I'll try to explain the questions. Feel free to drop your answer in the chat whenever you guys can. Awesome. Yep. The answers are flying in. I love it. You guys can either direct messages or drop it in the general chat. Important that you guys test yourself constantly on your anatomy knowledge. You guys are doing fantastic. Absolutely. The answer is E. Now, why are we spending so much time talking about the lumbar portion? This part is tested very heavily because the actual way everything kind of distributes from the vertebral section of your vertebral bodies are different as compared to the other regions. Your cervical and your lumbar are very unique. So here it is. This is the important high yield tidbit. So whenever you're looking at the vertebrae, right, and in terms of the nerves that essentially shoot out from the said spinal cord, you have to remember that if you're talking about a L4, L5 disc herniation, the L4 nerve has already exited. It's exited above the said herniation point. So the likely culprit that is affected by the herniation is going to be L5, right? L5 nerve is compressed, okay? The thoracic one isn't tested as heavily because it's fairly simple. So everything below it, right? If there's a herniation at the T7, T8 level, what's likely compressed? T7, right? It's very simple. It's straightforward. The cervical one is the other kind of complex one. The nerves that actually exit at the cervical region, there's less herniations there often. You're more likely to see some kind of misplacement of the bones or misalignment as compared to herniations. So what you need to remember is that at the cervical level, the nerve that exits is always the one above. So if it's a herniation, let's say hypothetically at the C4 and C5 level, C5 is the nerve that exits at that point, and that's the likely culprit that's compressed. So keep this general principle in mind because they love asking questions about this, and it's a fairly simple concept. If you have it down after multiple practices, you can essentially get it right. It's quick, easy points here and there. Okay. Once again, emphasizing the point at the cervical level, it's the exit and the compression is always going to be the one above. So what I mean by that is if you're talking about the vertebral level of C3 and C2, the nerve that's likely impinged is the C3 one. Okay. Thoracic is fairly straightforward. It's the one below. So T4 is the nerve that's going to be compressed. Okay. And the lumbar one is important because it's the exception. They can ask either way. They can ask which nerve is spared, right? Which spinal level is spared as compared to which one is actually compressed. So the questions can be either way. Yes, it would be the S1. Kayla, I think direct message me regarding that. Perfect. All right. So this is another important point, right? In terms of ligaments that stabilize the actual vertebral columns, right? You have several different type of ligaments that help essentially retain the shape that you're working with. Of course, these are ligaments, so they're not like, you got to remember that these are just ligaments and they're not muscles that are providing further anchoring. So important to know is the supraspinous ligament, supraspinous ligament, interspinous ligament, and the really most highly tested is the ligamentum flavum. Now, why should the ligamentum flavum ring a bell to you young MSK peeps? It's because it's the first pop that you hear when you're doing your lumbar puncture, right? Absolutely. Highly, highly tested. They love their lumbar taps for whenever you're talking about getting cerebrospinal fluid, okay? Once again, if I mention it at least twice or thrice, it's likely going to show up on your guys' exam. So important to note is that whenever you're talking about a herniation at the L4, L5 level, the nerve that is spared is L4. L5 is the one that is likely compressed, okay? And if you guys have issues with the sacral components, it's the same principle. Typically, they won't ask you about the sacral because most of it's fused, right? But they can ask about the L5 and S1. So the S1 is the one that is likely compressed and the L5 is spared, like Kayla asked. All right, let's do this question since you guys, we were just talking about spinal taps. Feel free to direct message me or Sayesha. Awesome. I love the answers with confidence. Okay. Now, the important thing to note that here, you have to read the question very carefully. What you need to remember is that the safest level, right, where the cord is actually terminating, right, is actually the L1, L2 level, right? So why is that? Because when you're going through this process, you have to remember that the spinal cord actually moves in a child, right? Like it, as the vertebral columns elongate and they get properly placed, right? The conus medullaris is actually moving up, right? As the baby grows, as well as the child, etc. And when you're a full-blown adult, right, it's basically hanging out at the L1 level, right? L1, L2 is roughly what's given. So if you go back and you take a kind of assessment of this, what you need to know is that for the safest level, because of the fact that the spinal cord usually terminates at the L1, L2 level, the best place that you would likely do it in terms of a lumbar tap is going to be the L4, L5. Okay.
Take a short, real quick. We have a question when we were talking about the spinal tap. Someone's asking if the first pop is the ligamentum flavum, is the second the dura mater?
Yes, it is. It's the first pop, ligamentum flavum. I like to think whenever I'm going through that, I like to think like the first flavor, like flavum, is the one that you like hear first. It's like the first pop of a, I guess, I don't know, popcorn or something. And the second pop is the dura, right? It's the tough mother. I like, if you guys need a quick way of remembering your meninges, right? This is a little bit aside. I'm pretty sure you guys covered this, but it's DAP, right? If you remember DAP, then you should be good on remembering your meninges. Dura mater, arachnoid, and then pia. And this is going from outside to inside, right? So dura is the tough mother. Arachnoid is like the spidery web kind of mother, I guess. And pia is the loving mother, okay? So DAP, just to keep that in mind, okay? All right, keep this in mind. They do like asking questions about this in terms of safety levels for doing your lumbar taps between your newborns versus your adults. It's highly tested. They love it, okay? And you guys asked, and here it is. So the first pop is ligamentum flavum. Second pop is the dura mater and the arachnoid mater and the subarachnoid space, because where you want to be is sufficiently where the CSF is hanging out. So when you're going past the dura mater, you're essentially trying to get to the CSF that's right here. Now, why do we do this here? Like, let's kind of make it simple because I hate memorizing random things for random sake. Since there's a whole bunch of nerves, right, and the spinal levels, first things first, this is called cauda equina, right, the horse's tail, because these are just fibers, right? The fibers are less likely to be damaged when you're doing a spinal tap and getting CSF fluid because they can essentially move out of the way, right? Because they're like fine threaded nerves, right? As compared to something as solid as the spinal cord. So that's why they like to do lumbar taps at the lumbar region, because the conus medullaris is safely away from the site that you're going to be tapping into. So once again, that's how I remember that lumbar is the preferential area, because that's when you're seeing your cauda equina, okay? Horse's tail. All right, this one is fairly simple. Keep it straightforward, okay? I basically memorize this based off of the shape, right? Lordosis, right? It's the L shape, like lumbar region. Kyphosis is dealing with your thoracic levels. And then your scoliosis, which is most commonly associated with what disorder? Feel free to put in the chat. Scoliosis is what? Love it. Polio. Exactly. So polio, right, misaligns this. And actually back in the day when polio vaccines weren't so apparent in, I guess, higher education, et cetera, they used to do in PE classes, they would actually ask students to like bend forward to essentially see if their spinal alignment was proper and if they needed to diagnose said patient during PE lessons about polio and if they have scoliosis. Okay. Now, this one kind of freaks out a lot of students, but I like to keep it very simple in terms of what you need to know. Okay. Dorsal root, it's essentially your sensory components, right? Your touch, vibration, proprioception, all of this jazz that essentially allows you to feel the external world, right? Whereas the ventral, right? I like to think if you guys have issues with in terms of anatomical orientation, dorsal, think of like dorsal fins of a shark or a dolphin, right? It's a quick and easy way of remembering it. Your ventral root is the motor root, right? It's the root where all of the motor components that are coming from your brain go downwards and essentially allows you to, I don't know, lift a heavy set of weights or, you know, throw a dumbbell at someone if they make you mad, okay? Be very familiar with this because this concept comes back time and time again, and they're going to continue to expand on it, okay? Now, the nice thing with this is, of course, it kind of goes all over the place, but what you do need to remember is that these are going to the site of where they're going to innervate, right? So think about it this way. If it's sensory and if it needs to go to your back muscles, what pathway is it going to take? It's going to take the posterior aspect and it's going to exit that way, okay? Ventral is for motor, okay? Keep that in mind. Ventral is for motor component, okay? The skin, right, of the back muscles are basically fed by the dorsal or posterior exiting point of this spinal nerve, okay? Now, what about your autonomic components, right? The autonomics are going to be typically at your thoracic, roughly to your lumbar level. So they have a lateral horn, right? What did I mention? I told you guys dorsal is sensory, ventral is motor, and the lateral is your sympathetic chain, right? If you guys remember your FTCM, not FTCM, FTM, sorry, we just had FTCM a hot minute ago. So FTM, if you guys remember, your sympathetic chain actually crosses over, right? It has your ganglion right here, and then there's a set of terminal ends as well as your neuronal somatic bodies that are essentially going to two places after they cross over. These are going to your peripheral limbs, and these are going to your back muscles in terms of sympathetics. So if you guys can keep this straight in terms of like where things go, it's fairly straightforward. The sensory and the motor components don't do this whole loopity-loop, how I like to think about it, in terms of the ganglions, right? The ganglions are specifically located, right? Your spinal ganglions, right? Not the dorsal root ganglion. That's just has your cell bodies for your sensory components. But the sympathetic ganglions, those are associated with your autonomic nervous system, right? Sympathetics, you guys remember epinephrine, norepinephrine from your FTM. Those kind of cross over and they go and innervate different parts based off of this crossing over point. They can also ascend, right? They can ascend and go to like your cervical regions as well, because there are components that don't have ganglions there, but they can ascend in terms of innervation wise, like you're seeing here. Okay, let's look at dermatomes. Guys, I want you to memorize this cold, okay? Especially the ones that are outlined in your SGU slides. It's very important because they like to ask questions about this. For example, you do need to know where your shoulders are in terms of dermatomal levels, and that's the famous C5, okay? The nipple line is often asked about. That's the T4. Okay. They ask a little bit about the umbilical region when you guys get to your term 2, but that's it's also good to know as T10. And then you can obviously like do the others. I always remember C6 because like you give a thumbs up and your thumbs up kind of looks like a 6 when you, I guess that's how I remembered that your thumbs were C6. And then if you guys remember, if it's C6, then the next thing that follows is C7 and C8. So in terms of dermatomal spread, it's C6, C7, and then C8 in your hands and your arms region. Okay, I want you guys to go through all of this and make sure you guys have it down cold. That's why I told you guys thumbs up, right? First aid, if you guys aren't using first aid, I highly encourage you guys. It's very important, constantly helpful when you guys are going through not only this module, but other modules as well, okay? Now, I like to think 7 letters in xiphoid, and that one's a difficult one to remember because you're like, what the heck is a xiphoid? It's the last tail portion, right? It's the bottommost portion of your sternum, right? It's the xiphoid process. It's famously called the solar plexus. You can actually, if you hit someone there, you can paralyze their diaphragm and kill them essentially. Fun fact with, you know, with me essentially. Now, important other ones is your diaphragm dermatome, talking about the diaphragm. C3, C4, C5 keeps the diaphragm alive. So 3, 4, 5 keeps the diaphragm alive. If you keep repeating that, it will make sense. And it also makes sense why it's associated with the phrenic nerve. And when we cover the phrenic nerve later on, you guys are going to see that it's associated with a particular type of pain when you guys are in upper terms as well. I'll cover that with you guys in review sessions. Let's do this question. Throw it in the chat. Awesome, guys. You guys are killing it. So this is a classic case of shingles, right? It's a herpes zoster virus. So you guys are going to cover this later on and in terms of the actual way it infects and does its magic. But the answer is B. And they love asking this question because herpes zoster viruses prefer to hang out in the dorsal root ganglion. And now the important thing, I don't want you guys to just memorize things. And even though MSK is memorization heavy, what type of cells are hanging out in the dorsal in the dorsal root ganglion? Is it cell bodies? Is it sensory? What type of, there we go, sensory? Are we talking about cell bodies or or the axons? Sensory cell bodies. I love it. Exactly, guys. Make sure you guys remember that. They like asking those first order questions based off of like third order vignettes. So it's a good quick point that you can grab here and there. Okay. Now, the important thing to remember with your dermatomes is that for herpes zoster, 3 regions have to be affected for it to be a proper presentation of herpes zoster virus, right? So let's say a lady comes in and she has dermatomes, she has her shoulder completely covered with the herpes zoster virus, right? In terms of multiple vesicles that are erupting, etc. Or whenever you guys are thinking about the vesicles, you guys don't have to worry about that too much. But let's say it's at the vesicles, right? The vesicles are at the C5, not C5, T5 level. What levels have to be affected in order for that presentation to appear? What dermatomes aside from T5? Put it in the chat. C5. What else? Yep, there you go. Important to know, it's one above and one below that is typically affected for the classic presentation of herpes zoster, right? So the example that I was working with you guys is, let's say it was at the T5 shoulder level, like let's say like this dude, right? You got to remember that what's going to be likely affected in terms of presentation is T4 as well as T6, right? Obviously, the example that they gave here is different, so keep that in mind. But you guys can play around with it, and this is how they like to test your dermatomal levels. Okay. Let's do this one real quick. You guys can just basically look at it and already probably pick your answer. All right. What's the diagnosis, young doctors? Yep, sacral coccygeal teratoma. Now, let's say you, I guess, rip apart this teratoma as a surgeon, right, in order to excise this. What would you find in there? Hair, teeth, because it has like whenever you guys are saying like pluripotent primitive streak, it has everything. It has all three dermatomal, well, not dermatomal, sorry, germ layers affected. So you can find anything from muscles to glands to hair and teeth. So keep that in mind when you guys are thinking about this. I never like memorizing MSK. I always learned it based off of functional and clinical anatomy. So as you guys mentioned, primitive streak, right, derived all three germ layers, hair, teeth, muscles, glands. So it can be anything. Let's do this question. All right, exactly. Nicely done, nicely done. Let's see a couple of other people's answers. Okay, we got a little bit of a distribution here with the answer choices. So the answer here is D. Okay, so this is spina bifida myelomeningeocele. So the nice thing with this is if you guys break apart the words, you guys can essentially make the diagnosis, right? It reveals a spinal protrusion, right? As well as spinal cord meninges, right? As a defect in the lower back, right? Um, do I have a trick of remembering and distinguishing this? Yes, I do. I'll describe it for you guys in a hot minute. Now, the important thing is any sort of neural tube defects, you got to give maternal kind of folate to prevent this. So that's why even women who are suspected to be pregnant or even attempting to get pregnant, they are put on folate right off the bat because within like the first 2 or 3 weeks, neurulation, which is the process by creating your neural tube, which is going to turn into your central nervous system, is essentially made. So how I remember it is spina bifida occulta. It's a cult of hair, right? Like a tuft of hair. So that's how I remember that. Meningeocele. So meningeocele is talking about cele is talking about fluid, right? Like hydrocele. Whenever you guys think of cele, think of liquid or water or some kind of substance. It only has meningeocele. So only thing that's affected is meningeo, right? The meningeal layer, as well as the cele, which is the CSF, right? And whenever you add the next component, right, meningeomyelocele, right? The myelo is talking about the actual spinal nerves. So whenever you're thinking of it that way, think of the spinal cord also herniating out. Okay, that was my trick of memorizing it. It's not even memorization. I just made it a practical application. So there you go. Like Sayesha is saying, break apart the words and it's going to make complete sense to you guys. Now, in terms of neural tube derivatives, remember the central nervous system is basically composed of the brain, brainstem, and spinal cord. Peripheral is all the somatic motor innervation and the preganglionic visceral motor portion. The neural crest derivatives, right, is really tested a lot and it goes a lot of different places. And you guys are gonna cover neural crest cells like nobody's business in every single module moving forward, all the way till when you guys take your first BSCE of year one. Okay. But just for the time being, I'd commit to memory the Schwann cells are part of the neural crest derivatives, as well as your maters, right? Your pia and arachnoid are from the leptomeningeus meninges, which is from the neural crest derivatives. Okay, those are the ones that they like to ask because it's very MSK tied in. Let's do this question while I try to check some water and not lose my voice. Okay, we had a little bit of mix of answers, and I know why you guys are often confused with this, but you guys are getting it. A good majority of you guys. Um, the answer is B. This is spondylolisthesis. So how I remember this was spondylolysis was the actual fracture, right, of the vertebral kind of body. More specifically, the isthmus, right? It's the neck that's likely broken from the Scotty dog. Now, I'm going to show you guys a trick of remembering this and how to identify it both in imaging as well as subsequent kind of sections. So let's kind of quickly go over it. So spondylolysis, right? Lysis, I like to think of lysing a cell or cutting or breaking apart, right? If you guys can remember, this is a Scotty dog, right? This is like a little like European dog, right? Obviously no dogs were harmed in the making of this, but like important to know. When you guys are seeing this, whenever you have the isthmus broken, that is spondylolysis, right? When it moves forward and it displaces forward the vertebral body, right? It is actually called spondylolisthesis, right? It's the lysis with the listhesis, which is the movement forward, right? Keep that in mind. It's kind of a slip, and like Sayesha is saying, there's a nice, fun way of keeping it in mind. Okay, here it is. Just identify a normal Scotty dog with its irregular old neck in place, right? You guys can see the little dog, which is a very crude outline, but here the Scotty dog's neck is broken, right? The isthmus is broken. The interspinous processes is what is damaged, right? This is the spinous process of the vertebral body. Okay, keep that in mind. This is commonly seen in the lumbar region. A lot of the times the dude is like deadlifting, like, I don't know, 250 pounds, and it's like wild, but like he just blows out its back because like, you know, the interspinous can't handle all this pressure that's being thrown at it. You can also have herniations with this too. But for now, just remember that it's the interspinous process and the pars interarticularis is what they like to ask about, okay? So if you guys remember the key terminologies that I'm mentioning, interspinous process, inferior articular process, and the superior articular process, where they articulate is the pars interarticularis, right? Interarticulate, which is connecting together, okay? Here it is in terms of the displacement forward. Remember, it slips anteriorly, so there you go. Now, I'm going to ask you guys, since you guys are learning this very well, what type of imaging is this? What type of MRI is this? I gave you guys a hint that it's an MRI, but what type of MRI? T1 or T2? T2. How would you identify your T2? What is going to glow up? The fluids, exactly. CSF glows up like a diamond, okay? It shines bright. Obviously, you're wondering, what is all of this shiny stuff? It's because of fat, right? Fat actually can, the adipocytes and the components that are laying on in the back can actually have a little bit of fluid in them, so it also shines up. But the CSF is the one that we're focusing in on right here, okay? Now, this is obviously what type of image, guys? X-ray, love it. Okay, I just wanted to give you guys a quick assessment of your guys's cumulative or your imaging knowledge. Let's do this question. All right, you guys are getting this exactly. Yep. You guys are doing fantastic. Remember, this is the odontoid process. This is highly tested because it's one of the more severe kind of spinal surgeries a person has to go in and correct. It can result in quadriplegia by the compression of the cervical level of the spinal cord. So if you basically squish down on the spinal cord at any point, especially higher up, it can present with quadriplegia. And obviously here, it's a cervical region, so quadriplegia is going to be seen. So what you need to remember is that the transverse ligament of the atlas, right, is what is affected. And a lot of people have issues with the atlas versus the axis. And how I remember that is the atlas is like a Greek mythology figure who holds up the world, right? Like literally Earth, he's lifting it up on his shoulder. So think about it that way. Atlas is what is the most proximal thing that holds up your skull, right? Like your entire cranial vault, right? And then your axis is the one that's below, right? So keep that in mind. It will help you out in terms of remembering C1 versus C2, okay? Adenoid fractures, which one is the worst? It's the type 2. It's very unstable. It has high levels of communicability, and it will help you a lot, okay? In terms of other ones, in what they like to test is the hangman's fracture. What can be likely affected is your C2 and C3 in terms of hangman fracture. Keep that in mind. This is literally like they used to hang people and it would snap their neck, causing spinal compression and death. It can also appear if a football player tackles the wrong way. You can have a Jeffersonian burst fracture. This is usually due to like a multiple kind of head trauma and wound, especially coming straight down on a person's neck or head. So it has multiple processes where it can break, okay? All right, compression fractures. This is like what it sounds. Fun fact, kids can actually get compression fractures, right? If you actually carry, since their bones are still forming, this is why the parents and like especially orthopedic surgeons will tell you not to overload their backpack with like books and textbooks and materials and everything, because their bones are still forming and growing, and it can lead to the compression of various kind of regions. Typically the lumbar region can be affected if it's a high amount of books, especially when they're growing. So these are more long-term in nature in terms of compression fracture. Okay, burst fractures are often seen with direct insult or assault to the spinal cord. So very simple. Someone hits you in the back with like, I don't know, a very blunt tire iron or something that can lead to a burst fracture. Let's do this question. All right. You guys are getting it. All right, perfect, guys. Exactly. So the answer is semispinalis capitis, right? Now, what you need to remember with this is that in terms of your erector spinalis muscles, I have a quick mnemonic for remembering them. And that is I love spinach, right? These are the erector spinae muscles. I love spinach stands for iliocostalis, right? That's the most lateral kind of part of the erector spinae muscles. Then there's the longissimus, and then you have your spinalis, right? I like to think spinalis is like so center because it's already on the spine and up to the thoracic level only. So if you guys remember that, you guys should be good. Okay. I love spinach is the buzzword of remembering this. Put that into memory and you're going to be good. Obviously, in terms of what you can likely get tested on for this is just straight up like they have some kind of issue with stabilizing their back muscles, especially your deep back muscles. And these are the ones that they're likely asking you about. They don't like to ask you too much about the innervation because it's way too simple of a concept. Posterior rami of the spinal nerve. Remember the sensory, when we were talking about the innervation, the dorsal root, right, also goes posteriorly toward the posterior rami. And then the motor also comes in and goes posteriorly as well as laterally, right? So if you guys remember that, it's very simple. And guess what? If it's vasculature and arteries running along the same line, innervation and vasculature is running along the same lines, it's very simple. Your cervical components, your posterior intercostal, and then your subcostal and lumbar arteries. It's all based off of the region that you're working with. So it's fairly straightforward of keeping this material straight. Okay. Okay. Now let's talk about your superficial back muscles. These are the muscles you can palpate if you were like literally pressing down on your back, right? The biggest kind of one that stabilizes your back is your trapezius, right? This is the one that does a lot of the work. This is the one that likely aches after studying for like 24 hours straight before an exam. So in terms of what they like to ask with this is, of course, what type of movement could be affected, right? This is typically shoulder shrugging, right? Your traps are involved with shrugging your shoulders. So if you guys remember, if you guys are going to the gym, a lot of people will do like trap shrugs, right? That's how I remember that the trapezius does shrugging as well as elevation of your thoracic cavity as well as your spinal levels, right? So keep that in mind. It's very simple, straightforward. In terms of innervation, that's the part that gets a little tricky, right? It gets innervation from C3 and C4, and then the motor component is the accessory nerve, right? The accessory nerve, you guys are going to associate that with cranial nerves later, but for now, just know that accessory is the motor component, and C3 and C4 are specifically for proprioception, right? And in terms of sensing where you are and how much tension you're putting on that said muscle. Blood supply, straightforward. Since it's at the cervical region, it gets blood from the transverse cervical artery. It's the superficial branches of it. The lats, right? These are the ones that everyone likes to work out with, right? Like every single time you do like a chin up or like shoulder press, your lats also are working. They are involved with extension, right? Extends adducts and medially rotates the humerus, right? So medial rotation is involved with the lats. Guess what? If it's at the thoracic level, the innervation is thoracodorsal, right? C6 to C8, thoracodorsal artery is the same thing. Levator scapulae, guess what? Elevates the scapula. This works in tandem with the trapezius, so keep that in mind. Obviously C3, C4, dorsal scapular nerve, right? Think about it, and it should make general sense. Now, this part always tripped me up in terms of what is above and what's below. Rhomboid minor and major aren't named based off of location. They're named based off of size, right? Rhomboid minor is actually superior and the rhomboid major is inferior, right? Guess what? They do the exact same thing because they are all involved in adduction and elevating the scapula. So don't even trip. It's very straightforward. Adduction, right? If you ever had to do adduction of your shoulder, right? Moving your shoulder towards you, right? That's your rhomboids also working together to do that said movement in tandem with other muscles. Okay. All right, I would commit this to memory in terms of innervation and vasculature. The back muscles aren't tested as heavily as your brachial plexus, but I'll go over these with you guys later as well. Okay, what's the mnemonic for your rotator cuff muscles, guys? Drop it in the chat. Sits, okay? Make sure you guys remember that it sits supraspinatus, infraspinatus, teres minor, right, and subscapularis, okay? And they tell you exactly what's happening, right? Supraspinatus, right, is okay. Make sure you guys go over the numbering for this because they like asking questions about specifically if a patient can abduct the arm up to 15 degrees, right? Like that's the supraspinatus, right? Innervation for this is suprascapular nerve, right? Most of this is done by the suprascapular nerve in terms of the sits, the supraspinatus and infraspinatus, because they have the spinatus in them. So it's the suprascapular nerve. The teres minor, important that you guys know this, it's the axillary nerve, right? Very, very much part of your brachial plexus testing that they like to do. So keep that in mind in terms of teres minor being affected. And then your subscapularis, guess what? Artery and vein and everything that's going with this is your scapular arteries and vein. Now, what do you think in terms of innervation? Subscapular nerve, okay? It's very simple. Keep it straightforward. Don't think too much about your sits muscles because they are just tested on based off of what is said on this slide. Okay, I threw this in because we had one or two questions about this. It wasn't highly tested because it's not that clinically applicable anymore. Back in the day when they didn't have really good stethoscopes, they used to have the triangle of auscultation, right? It basically was this window into hearing your lungs, not really great, and it's not really used as much now because our stethoscopes are so darn good. But what you do need to know is that the trapezius forms the medial border, the scapula forms the lateral border, and the inferior border is the latissimus dorsi. So that's the triangle right there. The triangle of Petit is a little bit more complex because you can actually have hernias from there, right? And that's the difficult part. If there's a clinical correlate, they like asking questions about this. So I want you guys to go one by one and make sure you guys commit this one to memory. What you do need to know is what we were asked about was specifically what was the floor of our triangle of Petit herniation. And I had a difficult time remembering that it was the internal abdominal oblique muscles because it's something that eluded me. I could remember much clearly the posterior kind of component, the anterior and the inferior, because it's something you can superficially kind of identify because you know where the iliac crest is, like you know where the external abdominal muscles are because you can literally palpate those. But the floor is a little bit more difficult to remember because it's deep seated. Okay, this one is really hard for one particular reason because of the way it's situated, right? Now, if you guys have ever gone on Instagram, and I highly encourage you to subscribe to a whole bunch of medical stuff. So even when you're on Instagram, you can look at a bunch of like medical content and put it into memory, which is the way I remembered this. So what I used to do is make basically a hashtag sign with both of my hands, right? And that basically told me where each of these spaces are, right? So I would make this, please don't make this on the exam, you're gonna get flagged. I don't want you guys to get in trouble. So what you do need to remember is that there's the triangular space, which is like right here. There's the quadrangular space, quad meaning four. So there's four sides to it. And then there's the triangular interval, which is like right here, right? So if you guys remember that, now what you need to put into memory is what exits from each of these points, right? And the bordering for this. So I would commit this entire thing to memory. They like asking questions about this in terms of shoulder dislocation. Remember, it's typically whenever you displace your shoulder, anterior and inferior, and what nerve are you going to injure? It's because the quadrangular space is right there. It's going to be the axial artery and the posterior humeral circumflex, okay? That is a exam question that I'm giving you guys right off the bat. This is a fantastic kind of question that they can build as a multi-level assessment of your scapular muscles as well as your humerus, right? Cool. The ligament that's typically affected is the acromioclavicular. I'm going to cover that with you guys. And I'm going to tell you guys, whenever you guys are going through this, if you can draw it out, it's going to put it into memory. If you guys are big whiteboarders, I know Sayesha is a big whiteboarder. I personally draw all my notes on my iPad, and it's fantastic. Now, a little jumping away from our muscles and bones and whatnot, we're going to get into the aortic arch. And this one is really important because you're going to revisit this in almost every term that you're going to be here at SGU. What you need to remember is that the aortic arch is, a way I remember it is that the branches of it is vitamin C and D, okay? V, I, T, C, and D, right? If you guys can remember that, it's going to help you a lot. So what you need to know is that the V is standing for vertebral artery, right? I is for the internal thoracic artery, and the T is for thoracocervical, and the C is the costocervical, and D is one of the more accessory muscles. It's not often asked about, but I threw that in there. I think it's the dorsoscapular that's a branch off of this. Double check your notes on this, but it's most likely that you're going to be tested on is vitamin C kind of components that are branching from the aorta. Okay. The reason you need to know this is because the scapular branches are coming from these kind of offshoots of the aorta. Okay. All right. Now, this one always scares people. What you do need to remember is that there's a nice mnemonic for this. It's a little dirty, but the dirtier the mnemonics, the easier it stays in people's heads. 60s teen, love, sex, and pot. Okay. So what am I talking about? You're like, what is he talking about? Like, what is this confabulation that's happening here. Now, the most proximal thing for S, right, 60s, right, is the superior thoracic, right, which is a branch that, remember, the arteries have already come out from your aortic arch. Now, what they're doing is once they cross the first clavicle, right, once they cross the first, not clavicle, but your first thoracic rib, right, it's going to then become the superior thoracic, right, sorry, it's going to, oof, I am falling apart. It's going to become your brachiocephalic artery. Your brachiocephalic artery has different parts to it, okay? Remember the brachiocephalic, as it's going down, it's eventually going to become the axillary artery, right? That's a huge giant artery that's going to go to your arms. So keep that in mind. The first point it crosses over, that is critical to note after the first rib, okay? Now, the first branch off of the brachiocephalic artery is the superior thoracic artery. Now, make your anatomy correlates together, right? If it's superior thoracic, it's going to give you branches to your intercostal muscles, right? They are basically the ones that stabilize the rib cage, okay? Keep that in mind. They also are involved with elevation, a little bit of your rib cage when you're taking an inspiratory breath in, but don't worry about that. That's a CPR problem for now. The next thing is teens, right? The thoracoacromial, there's a nice way of remembering this. Cadavers are dead people. The branches of the thoracoacromial is clavicular, acromial, deltoid, and pectoral, right? If you guys remember that thoracoacromial has these branches based off of cadavers or dead people, you are straight in terms of the branches that come off of it. Now, the lateral thoracic is the love part, and then sex is associated with the subscapular, and that has obviously your thoracodorsal and your circumflex scapular, but that one isn't tested too much based off of this. Circumflex scapular is mostly tested based off of anastomoses, and I'm going to tell you guys that the anastomoses are high yield and how I remember them. And then, of course, POT is talking about the posterior humeral circumflex. The anterior humeral circumflex isn't tested a lot because the anterior humeral circumflex has nothing really impinging on it in terms of vasculature. So keep that in mind. You guys should be good. Okay. Remember this mnemonic and it will save your life as it saved mine. Okay, guys, scapular anastomoses. You're like, there's too many arteries. There's nothing I can do to remember them. There is. It's a very simple way of remembering them. If they ask you for any sort of scapular anastomoses, it has the word scapular in it, right? So if you guys see that common denominator, right? It has circumflex scapular artery, suprascapular artery, and the dorsal scapular artery all have the word scapular in it. And that's a quick point that you can grab on the exam based off of just that general trend, okay? Let's do this question. Absolutely, guys. You guys are doing fantastic. So what is the likely ligament that's messed up based off of this? It is the acromioclavicular ligament, right? Now, I'm a firm believer of making sure you guys are palpating and making your anatomical landmarks, because obviously you're not slicing open a cadaver to really see what's going on. Now, the acromion process is actually right behind the back right here. And if you guys palpate it, it's like this little bony process. And it's the point where the clavicle and the acromion connect, right? And that ligament stabilizes these two essential bones, right? Which is part of the scapular kind of bone. Now, the other one that they like to ask about is the coracoclavicular ligament. The acromioclavicular and the coracoacromial are the ones that they love to ask about based off of the shoulder dislocation. The first thing I like you guys to do is basically take your finger and palpate the little bony kind of protrusion. If you palpate it hard enough, it actually kind of hurts, right? Because it's a bone that you're essentially rubbing against. That is the coracoid process, right? The coracoid process has a ligament that stabilizes it. And since it's anteriorly located, it anteriorly holds the clavicle in place. Because remember, the clavicle has to move around a lot. Because remember, it's kind of like this stabilizing point. It's a very weak bone by itself, unless it's stabilized by a lot of ligaments, right? That's why you have the acromioclavicular and then you have the coracoclavicular ligament, right? The most often one that they like to ask about is this in terms of shoulder separation, dislocation, etc. All right, now I told you guys about the sits muscles, and this is a first aid mnemonic. I personally use this so many times to save my exam score for MSK. The first thing you need to know is that you guys know your sits muscles, right? In terms of what innervates them, what type of trauma it is. Now, the quickest way that they like to ask about is the patient is negative for, or sorry, their patient is positive for the empty can test, right? Now, what muscle is being tested if I told you guys a patient comes in and they're positive for the empty can test? What muscle is likely traumatized or ruptured? Supraspinatus, right? Keep that simple. That's the favorite one that they like to ask about in terms of the empty can test. It's basically testing your sits muscles right off the bat. Now, the arm abduction is really important. I think the SGU numbers for the degrees of abduction, right, is different to the one that is given in first aid. Go based off of the SGU slide. Oh, sorry, for someone who's asking about the empty cans test, it's right here, right? It's for assessing their supraspinatus muscle, right? Basically, you take pretend like the patient has a can and you ask them to empty it, right? And that is using your supraspinatus muscle to essentially assess for if there's any sort of rupture or trauma, okay? Now, in terms of arm abduction, keep this very simple. Memorize the degrees that SGU gave, but I threw in the first aid because it's very helpful to keep it simple. They like to ask about, let's say the patient is unable to abduct their arm, I think 15 to 90 degrees, then remember it's the axillary nerve that is likely damaged due to what? Patient has been either working out too much, right? Remember, quadrangular space can be affected. They have a shoulder dislocation. These are all good hints as that you have a deltoid level issue. Okay. My favorite one is serratus anterior. It's long thoracic, and remember that if you guys remember SALT, right? You know that serratus anterior is associated with long thoracic nerve, and that is anything above 90 degrees. Okay. Yep, that's a very good kind of statement right there. Unable to reach up and brush their hair 90 degrees and above. That is fantastic. Keep that in mind. It's really helpful. All right, brachial plexus. Now, the way I remembered all of this in terms of what is messed up is real Texans drink cold beer, right? Roots for real, Texans for trunk, divisions for drink, chords for cold beer, and then cold beer is, of course, terminal branches, right? The beer part is the terminal branches. Okay, that's the essential things. Now, obviously, you need to know the spinal levels that you're working with. And remember, the brachial plexus is from C5 to T1, right? And I'm going to show you guys the little hand mnemonic, how I went through this. Let's do this question. These are just like how they're going to ask you these exam questions. So keep that in mind. Make sure you guys are doing plenty of grays because it's golden. All righty, exactly. Now, what is this presentation, guys? What does this kid have? There you go. Herbs policy. Nicely done. You guys are diagnosing patients as they're coming in. This is actually a real life situation. Whenever you have a tough delivery, the physician might go in with certain instruments that can essentially move the baby's head to one position. And in that process, they can affect the patient's brachial, or I mean, child's brachial plexus, and the upper trunks are the likely culprits that are affected here. Herbs is the typical one. Now let's do this question since you guys know so much about herbs. Now tell me what's going on. All right, guys, killing it. Exactly. So remember, it's the inability to laterally rotate the arms. Now, why is this happening? It's because these specific nerves can be messed up, right? Your suprascapular nerve, your axillary nerve, your musculocutaneous, and the mnemonic for that is SAM, right? The SAM muscles are affected in your herbs policy. Highly tested. They love asking questions about this. Remember, for herbs, what not cranial nerves, what spinal levels are affected? Put it in the chat. C5, C6, and 7. Okay, the 7 part can vary. Okay, so that's the point I want to emphasize. Remember, herbs policy associated with C5, C6, plus or minus 7 in terms of how it is. And exactly like it's mentioned here, SAM is the way you can remember the herbs policy component. Okay. All righty. Let's do a clinical case. The babies look at, like Sayesha saying, fantastic. It's unable to rotate laterally. It's only medially situated. It's because of nerve damage, right? Especially the upper portion of the brachial plexus. Okay. Now, Klumsky's policy. If you guys remember your Klumsky's policy, I want you guys to remember your Klumsky's claw, right? It's where the patient's hands are clawed-like. Why? Because what not dermatomal or spinal levels are messed up? Put in the chat, just so I want you guys to be awake and with me. C8 and T1, absolutely. That's highly tested. They love that. Now, what is messed up? Now, what is causing this kind of clawing of their hands? It's because their lumbricals are normally flexing the MCP joints and extending the DIP joints, and the clawing is associated with the intrinsic hand muscles kind of losing their capacity. Now, the loss of the flexor carpi ulnaris and the medial 1/2 of the flexor digitorum profundus, okay? Here it is. I love this first aid picture. It's fantastic. It pulls it all together based off of each disorder or presentation. Remember, thoracic outlet syndrome, it's going to be the same as Klumsky's policy in terms of presentation, because what gets messed up, it's the same CAT1. It's the lower portion of your brachial plexus that's traumatized, right? By the extra cervical rib that's coming out. This is a more congenital in nature. Patients can survive with this, but of course they're going to have some, they need to go into some physical therapy, right? You can also surgically kind of correct this too if you need to. Now, winged scapula, this is a buzzword. Remember, I told you C5, C6, C7, wings to heaven, right? That's the SALT component, right? SALT, long thoracic is affected. So SALT. So if you, the way they're going to say it is the patient is positive for winging of the scapula, and you need to know both the musculature as well as the innervation that could be likely messed up. Okay. They won't ask you guys too much about the whole mastectomy and stab wounds, but they preferentially like tend to go with the whole like winged scapula assessment. Okay. Now, your dorsal scapular, like let's look at a couple of the branches that are coming off of the brachial plexus. This is coming directly off of the roots, right? Remember real Texans, right? Roots for real. These are the ones that are coming off more proximal to the spinal level, okay? Dorsal scapular, right? Guess where this is going? This is going to your rhomboids and your levator scapulae. Okay, so imagine, what can you not do? You can't do the adduction, and the levator scapula can't elevate. So you're going to have some effect on that. Now, remember, your diaphragm can also be messed up because what did I say? C3, C4, C5 keeps the diaphragm alive, right? That is your diaphragmatic muscle, and that is associated with your phrenic nerve, okay? Phrenic nerve, highly tested every module, 10 out of 10, need to know it even now. Obviously, if you have issues even more proximal, right, with the serratus anterior, guess what? Winged scapular test is going to be positive here as well if you have root level damage. Now, let's look at a couple of other branching points, supraspinatus and infraspinatus, right? It's based off of your suprascapular nerve, right? And then there's also the subclavius. Subclavius isn't tested as heavily. They do like asking questions about the supraspinatus and the infraspinatus. Know that very well, guys. The next component, okay, that is often asked about is pectoralis major, right? The patient is unable to do the adduction motion using their pectoral muscles. It's basically destabilized. What's affected? Remember, it's the lateral pectoral muscles or the medial pectoral muscles that's likely affected. If they say major and minor, then it's going to be medial. If it's just the major, then it's going to be lateral, okay? The subscapularis, right? Muscle is affected by the upper subscapular nerve. That wasn't heavily tested, but what I do want you guys to know for sure is your lower subscapular, that's going to the subscapularis and the teres major, and the latissimus dorsi associated with the thoracodorsal, okay? You guys see why the brachial plexus is so important, right? It's because there's so many branching points that are coming just before it's even going to your upper limbs that so many muscles in that area can be affected. So make sure you guys are assessing yourself constantly on this. Draw it out. They love asking questions about the brachial plexus as well as the lumbar plexus and sacral plexus. Okay. The way that a lot of people learned it was via Marmu. I personally did not like this. That's just me. I personally prefer this kind of memorization tool in terms of innervation. Now, obviously, you guys know your C5 to T1 is your brachial plexus, right? So your thumb is C5, right? Your just how I remember it, C5, C6, C7, C8, and T1, right? Now, let's start off the bat with your musculocutaneous nerve, right? This is, we're getting into your lower limbs now, not lower limbs, but your upper limbs, but your innervation that's going to the upper limbs. Three musketeers, right? Think M. So three musketeers. So C5, C6, and C7 is musculocutaneous. The assassination, right? Assassinated. So axillary. So that's going to be C5, C6, and then 5 rats, 5 mice, and 2 unicorn, right? 5 rats is talking about the radial, and then your mice is talking about your median, and then the 2 unicorns is the ulnar, so CAT1. Keep that in mind. That's how I memorize it, and it helped me a whole bunch in getting a whole bunch of questions right, okay? The humerus, in terms of fracture or dislocation, let's say we are at the surgical kind of head of the humerus, right? Let's say a patient comes in, they've fractured it or dislocated it. What's the likely nerve that's damaged? That's coming out of your quadrangular space. Hint, those are all very key words. It's telling you axillary nerve. So what muscle gets affected? Your deltoid muscle, right? As well as a couple of other muscles, but deltoid is a major one. So you're no longer able to abduct, right, as well as you properly should. Then the posterior humeral circumflex artery can also be impinged or ruptured based off of this location, right? Highly, highly tested. Need to know it, guys. Now, the mid-shaft fracture is associated with your radial nerve and your deep brachial artery. Important because the presentations for mid-shaft fracture versus later on, what you're going to see is your forearm being damaged is completely different. So keep that in mind. Highly tested. Need to know this. Let's do a question on it. Yep. Yep. Exactly. You guys are getting it. The answer is C, right? It's the radial nerve and it's a mid-humerus likely injury that you're looking at. So keep that in mind. The patient is unable to extend their left wrist, fingers, thumbs, because what is messed up? It's the radial nerve, right? And although they can extend the elbow, because remember the innervation is still going at the elbow level to a certain degree, and then everything more distal to that is affected, okay? There's branches that's already given off. Okie dokie, let's take a look. Remember, the branch to the tricep brachii exits the radial nerve before the midshaft, so the extension of the upper arm is intact. That's very critical. A lot of people miss that in terms of knowing that the radial nerve midshaft injuries can have elbow function intact, okay? Now let's talk about supracondylar fracture. This is the median nerve. This is supracondylar. Don't get it twisted with the epicondyle. So this is median nerve is affected. So keep that in mind. Here you go. Epicondyle, that's the ulnar, right? Epi meaning more superficial. So medial epicondyle fracture, ulnar nerve, right? Now, remember the thing with this is always anatomical spacing. It throws off a lot of people that ulnar nerve is more medial to a patient as compared to the median nerve, right? The median nerve is just talking about the middle. Median is middle, right? So keep that in mind. Don't switch up your terminologies with this, and it will save you a lot of confusion. Okay, now this is very, very important, right? Any sort of humerus fracture, it goes by the term arm, right? If it's a more proximal, it's going to be something like surgical neck level trauma to the humerus, it's going to be axillary nerve. If it's midshaft, right, radial, and then more so that's supracondylar, that's going to be median. Obviously, you guys learned the epicondyle portion, that's going to be ulnar. So based off of that, you can understand any sort of sensory loss regionally based off of all of this, right? Both the radial nerve being disrupted, median, and the ulnar, right? In terms of sensation that's retained or lost. Keep that in mind. They like to also test you guys on sensations. So make sure you guys review this slide very well. All right, vasculature. This was a lot, okay? It kind of scared me about by the amount of stuff that I had to kind of put into memory, but I will tell you guys what they preferentially like to ask questions about, okay? The first thing that they like to ask about is the axillary artery, okay? Remember that the axial artery is, like, I like to think your arm, right? Axilla is also the armpit, so that's how I remember that the axillary artery is located near the armpit region. It's a vital blood supply to everything that's going to your upper limbs. Very, very important. Now, the other thing that they like to test on is the brachial artery, okay? Brachial artery, radial artery, the interosseous artery, as well as the ulnar artery. Those are the ones that they like to test on. Everything else is like you can learn it, but it's less likely to be tested, okay? Now, the veins that are likely tested, remember, it follows the same kind of patterning in terms of the arteries. Axillary, I would also put into memory your brachial and your basilic. The favorite one that a lot of people like to use in terms of, venous punctures to draw blood, as well as, I don't know, illicit drug injections, is the median cubital, or sometimes they can also call it the basilic, right? It depends on where they actually do the puncture, venipuncture. The other thing, obviously, you guys know your radial vein as well as your ulnar. Okay, I would know these two very well because they like asking questions about those as well. Okay, let's do a question. Yes, is the median cubital in the cuboidal fossa? Absolutely, guys. That's a great way of remembering it. It's basically the indentation where you are where you do a lot of your venous draw of blood. Okay, cubital, I think like that little indentation where your elbow joints meet, that's your cuboidal fossa. All right, guys, exactly. This is annular ligament. This is nursemaid's elbow. Fantastic. Nicely done. This is straight up a question that you guys are going to get on your exam. At least one question on this. So it's annular ligament. Remember, the kids' ligaments and joints and bones aren't fully formed yet. It's quite easy to pop out in most situations. So let's just say, a kid is running in the playground and the nanny or someone pulls on his arm, his or her arm, and boom, it displaces the radial head. What is the cause of it? It's the annular ligament essentially allowing for the bones to be popped out, right? The radius is the one that gets popped out. So keep that in mind, okay? Exactly. Just a quick thing in terms of putting this, what you need to remember is that the radius and the capitulum are the articulating point versus the ulnar and the trochlear, right? So very simple, keep that in mind, the articulating points, and right behind it is the olecranon process, okay? Very simple, straightforward. It's just articulating points, just a little bit of your tidbit information. Now, what you do need to memorize is your median nerve and the radial artery, or sorry, median nerve and the radial nerve, as well as ulnar artery, okay? Because the branching of it is slightly different. First thing to note is the anterior interosseous nerve is coming from the median nerve, right? And the radial nerve is coming from the posterior interosseous, okay? That's the branches that they give off. The ulnar artery is associated with both the anterior interosseous artery as well as the posterior interosseous, okay? Keep that in mind. They like asking questions on it. And as you can see, they're named very similarly, except for the artery and the nerve part. So very easily you can kind of get tripped up on your anatomical feeding points that provide both innervation and vasculature. Let's do this question. Pads and dabs. You guys are killing it. I love it. Okay. Okay. Yes, it is the flexor digitorum profundus, right? Now, remember, the way I remember this, right, which is the distal interphalangeal joints of the fourth and the fifth digits, right? The way I remember it is if it's distal, it's kind of profound. It's far out there. So if it's profundus, you're talking about your distal interphalangeal joints, right? And like you guys are saying, ulnar nerve, okay? You guys are killing it. I love it. Okay. Remember, the medial 1/2 is associated with digits 4 and 5. Because remember, medial, we're talking about your pinky and your ring finger, right? Your lateral 2 are associated with digits 2 and 3, right? 2 and 3 being your middle, well, I mean, it's your pointer finger as well as your middle finger, right? That's associated with your median nerve. And that's a branch off of the anterior interosseous nerve, okay? Keep that straight. Remember, it's 2 different branching points in terms of innervation. Okay, like I mentioned, 2, right? 2 here and 2 right here. Sensory is kind of similar in the same sense, so don't spend too much time getting too crazy into the bogs of knowing every single branches. They really like to ask if it's the median nerve affected versus the ulnar for the distals, okay? Now, the proximals are a little bit more different, right? It's the superficial ones. So if the superficial is the median nerve, so it's going to be only associated with the proximal interphalangeal joints, right? Proximal interphalangeal, so proximal more closer to you, median nerve. All right, dirty mnemonics galore. This is the most famous one. I threw that in there because it's well worth it to know it. Some lovers try positions that they can't handle. Scaphoid, lunate, triquetrium, pisiform, trapezium, trapezoid, capitate, and hamate, okay? Love to test this thing, okay? They love the scaphoid, okay? Scaphoid fractures are their go-to. They can also talk about the capitate, and then they can also talk about the, I think some of the lunate level fractures can be also there, but those are the basic ones that they like to test on. Remember, this mnemonic is only, it only works if you're putting it in anatomical position, right? If your thumbs are on the lateral kind of sides in anatomical position, it doesn't work any other way, so keep that in mind. Let's do this question because this one is a famous one. They love asking about this. Exactly. Exactly. You guys are killing it. It is a scaphoid fracture. Keep that in mind. Famous one. Now, whenever you have a scaphoid fracture, what artery can be associated with this? Radial artery. Okay. Important. Radial artery runs very close to this region, and boom, you're gonna exactly. Foosh is always scaphoid. Exactly. Falling with outstretched hands. They love asking that. Exactly. Go with that, and you're gonna do fantastic. Exactly. Radial artery, avascular necrosis. What about dislocation, guys? Exactly, lunate. And it's a posterior dislocation. That is a buzzword. So keep that in mind. Anterior dislocation of the carpal bone, which is the bone is most likely dissociated. Important is the lunate. Okay. Now, the anatomical snuff box is what I wanted to kind of emphasize on. And you guys remember, if your scaphoid is essentially ruptured, remember, the artery that's running here is the radial artery, right? It's the artery that you can palpate when you're taking a pulse on a patient, right? So think about it in anatomical positions. What other things could likely be dealing with the anatomical snuff box in terms of landmarks? I want you guys to memorize this. This is highly tested. Know each of the borderings. Know your abductor extensor pollicis brevis makes up the lateral border. Medial is the extensor pollicis longus, and the roof is the superficial radial artery in the cephalic. That's the one that likely gets ruptured. And then the floor is the trapezium and the scaphoid. Okay, very, very much tested. Let's do this one. If you have any questions, I believe Sayesha's dropped from the call now. Feel free to unmute yourself and ask me. You guys are good. Shoot. Okay, perfect. You guys are right. It is a Smith's fracture. So what is the difference between a Smith's fracture and a Colles fracture, guys? Posterior versus anterior. Exactly. Okay. Keep that in mind. They love asking questions about this. A Colles fracture, right, versus a Smith's. Remember, a posterior fracture meaning a distal fragment that's fractured posteriorly, like the fragment has moved, right? So sometimes they might use the buzzwords dinner fork versus the garden spade. I personally didn't memorize it that way. If it's posterior, it's Colles fracture, right? Keep that in mind. And the Smith's fracture, it's anterior displacement, right? Anterior displacement of the fragment. Okay, nicely done. Keep that in mind. They might give you a radiograph image of it. You have to know where it's moved. You have to know your lateral versus your direct view on an X-ray. Anterior, posterior view. Sorry. Let's do this question. Yeah, this one is, I believe we got a question on this as well. So keep this one in mind. Remember, this cannot be the median nerve. Now, why is that? Because the cut is to the is actually to the surface of the flexor retinaculum, but not into it. That is the key distinguishing factor here. You just have to remember this, right? This is what gives it away that it cannot be the median nerve. It can trip up a lot of folks. So keep that in mind. It's actually the ulnar nerve that innervates the adductor pollicis muscles. Remember, adductor pollicis muscles on the lateral side, and it's innervated by the branch of the ulnar nerve, okay? Adductor pollicis. I'm going to go over the adductors versus the abductors. The way I remembered this was ophs, so pads and dabs, and then oph muscles, right? I'm going to go over all of them just so you guys know. Remember, your thenar components have the oph muscles, right? Like the opponent's pollicis, abductor pollicis brevis and the flexor pollicis brevis. Whenever you think of brevis, think of your thumb, okay? Pollicis is dealing with fingers as well, but like, don't worry about it. Just think of brevis and you will make sense as to if you're in the thenar eminence versus the hypothenar, okay? Now, your dorsi muscles and your palmar are associated with your dabs and pads. Dorsals do abduction, pads do palmar adduction, okay? Let's do this one. Median nerve, right, is associated with the opponent's pollicis, abductor pollicis brevis, and the flexor pollicis brevis, right? Told you guys these are both done by the innervation of the median nerve, right, and the lateral two lumbricals, right? Because whenever we're talking about the median nerve, one half of it is done by the median, the other half is done by the radial. Keep that in mind. It's a very simple concept if you follow the divisional lines of the sensory as well as the muscle movement associated with your hands, okay? Now, the ulnar nerve is specifically associated with the opponents, right? Like the oaf muscles, right? Opponents, digiti minimi. Whenever you think of digiti minimi, think of your minimi. I'd like to think of your pinky. And then your abductor digiti minimi is also the same thing. And the flexor digiti minimi is all telling you what each of the muscles of the pinky is doing. And obviously the medial two lumbricals are thrown in there as well as the interossei muscles. And this is the hypothenar muscle group, right? Ulnar nerve branch. This is the one that's more medially located. Keep that in mind. It throws off a lot of people, the terminology between the medial versus the hypothenar and the ulnar. Don't get it twisted with the median nerve, okay? Lumbricals, right? You have your DIP, PIP, and your MCP, right? Your lumbricals are allowing you to make this kind of L-shaped movement. It's very critical. Now, whenever you're thinking about it, is L for lumbrical is the shape that is forming. So what are the two components that you need to keep in mind? The median two lumbricals and the lateral two lumbricals are flexors. The exception is the lumbrical at the IP joint. Because what did I tell you guys about the interphalangeal? It's the extension of the PIP and the DIP, and it's the one that throws off a lot of people in terms of the actual innervation and the movement associated with them. Okay, dabs and pads, ulnar, right? Whenever I told you guys dabs and pads, think ulnar. It's associated with the dorsal interossei abductor as well as pads, palmar interossei adductor muscles. Movement wise, just make this and you should be good. It makes sense, right? Why is this out? I don't know why it was not showing you guys interossei. There you go. So these are your dabs and pads. That's the movement that they're allowing you to do. So I always like to learn this anatomy based off of a functionality. So that's the way I know the dabs and pads till this day. Okay. Benediction attitude. This is a buzzword heavy portion. Make sure you guys learn these buzzwords like the back of your hand. Get it? Because we're in the hand region. Exactly. Okay. I like to think Pope Benedict is a pope who is on the median path, which is the path in the middle, right? That is my way of remembering that it's associated with the median nerve that's likely injured. And these are the buzzwords for it, right? The Pope's blessing. So the thing that confuses a lot of people is what type of movement the patient should be making, right? What you need to tell them is make a fist, right? If they're unable to make a fist and their thenar component is the one that's hanging out and the hypothenar is working just fine, that's telling you it's the median nerve, right? Now you ask them to make, you ask them to spread apart their hands, right? That's the extension at the fingers and at rest. That's the distal median nerve. And then the OK gesture, right? That's coming in by making a fist. That's the hypothenar. So that's the proximal ulnar nerve versus the ulnar claw. That's the distal ulnar nerve. Okay. Make sure you guys know this clawing of the hands based off of various situations. Okay. Let's take a 5-minute break. I'm going to hang out here, get some water, and I will try to answer any questions that you guys have in the meantime. Welcome back, guys. Hopefully you enjoyed your break. Now let's do the thorax. Now the thorax isn't too crazy. Obviously, you're going to spend a little bit more time on it when you're going through your CPR module, but there are a couple of high yield concepts that are going to be tested over and over again. And I want to make sure you cover that before you guys show up to CPR. Now, remember in terms of your neurovascular bundles, the mnemonic is Vance. And that's really important because whenever you're doing a pleural tap or a thoracostomy, important to remember is not to hit one of these. That's why you're going to go at the inferior, right, nerve, and then you're going to go this way, right, puncture right through and not hit the lungs, right? So the important things is you don't want to hit the neurovascular bundle, which is the Vance, right? All incisions and tubes have to be placed at a unique angle, right? Travels via the costal groove of the inferior aspect of the rib. So right here is your Vance. So that's why you try to avoid it by going superior to your actual rib, okay? When you're doing the actual insertion, right, you want to make sure the patient is not moving too much because you don't want to puncture their lungs. Obviously, there are particular locations where you want to go. Those locations are like your midclavicular line, your mid-axillary line, and then your paravertebral. And that tends to be the one that is often tested. I'm going to go over those specific numbers with you guys, but obviously, for a pleural tap, whenever you have high levels of edema or pleural effusion, where stuff leaks out into the pleural space, you want to assess for it, right? That's why you do a thoracocentesis. You aspirate some amount of fluid or anything that's hanging out in the pleural space, and then you can test for it. The angle of insertion is superior to the inferior rib. That sounds a little confusing, but it's the inferior rib right here, and you go superior to it so that you avoid the Vance, right? Which is the veins, arteries, and nerve, right? That are in the space a little bit above to the rib that's above you, okay? Obviously, you don't want to puncture any of this because you're going to paralyze their intercostal muscles, and that's not good because these muscles have to move. But luckily, the chances of you guys messing this up is very, very few. Okay. Now, the needle insertion is into the pleural cavities obtained to get sample. So ninth intercostal mid-axillary line during expiration so that the lung fields are clear, right? You're expiring out, your lungs are basically being pushed up and compressing to release the air out. So less likely that you're going to poke the patient. Let's do this question. You guys are killing these questions. I love it. Exactly. It is the 11th space. Now, the appropriate insertion is at the 11th, and I'm going to show you guys why that is. Let's take a look. This is the costodiaphragmatic recess that you're trying to tap into. This is where a lot of fluid can hang out. And when you guys get to upper terms, they're going to cover the type of fluids that you can actually pull from here based off of heart failure, based off of pneumonia, so on and so forth, right? Just keep that in mind for the time being. The important numbers to keep in mind is 6th and 8th, 8 and 10, and then of course, like you know your 10 and 12. Obviously, the numbers in between are the ones that are most important. So keep in mind the 7th space, as well as the 9th space, as well as the 11th space. So how I remember it was 7, 9, 11, right? 7, 9, 11 is the numbers that you need to keep in mind as to where you can likely do the puncturing. They just give you the rib numbers just so that you have a margin to work with. In terms of what they like to test are the ranges. If they don't give you the ranges, I want you guys to remember 7, 9, 11. Okay, just putting that into your thought and making sure you guys remember it. Okay, I don't know why they like this. For some reason, they just have a fond love for this type of question. So tell me what you guys think. Okay, we have a little bit of confusion. Some people are saying D, some people are saying A. Now the answer is actually D. It's the descent of the diaphragm and the protrusion of the abdominal wall, thereby increasing the vertical dimension of the thoracic. So what are we talking about? If it's increasing the vertical dimension, we're talking about your pump handle, right? Um, I don't know why, like it's just a way I remember it. Like the pump handle, you're pumping up and down, right? So like anterior, posterior, for some reason in my head is like up and down. Versus the bucket handle, it's more lateral, right? Like how do you carry a bucket? You don't carry it straight in front of you, you carry it on the sides. As someone who's carried a lot of buckets of water back in my day, because I grew up in India, uh, for some reason, I always had difficulty carrying it, so it's always be on my side. So that's how I remember bucket handle, lateral versus pump handle, anterior, posterior dimension. Okay, let's do this question. This is a favorite one. They like to, you get tested on this all the time based off of cancers. We are actually learning it again when you guys get to term for in terms of oncology. Exactly. So you guys are fantastic. Anterior axillary is the pectoral one. This is the first one that your likely metastasis is going to go to. The other one, if they talk about in terms of metastasizing to the other particular breast tissue, is the peristernal, right? And it can basically cause any sort of, let's say, breast cancer here to metastasize over to the other breast tissue. Okay. Whenever they ask you about sentinel nodes, the likely go-getter that you should pick is the anterior nodes. If they're talking about metastasis going to another breast tissue, then pick the paracentral, sorry, not paracentral, peristernal nodes. And that's the one that we can talk about metastasis. But a good chunk of it is always going to be the axillary nodes and the anterior nodes if they don't test you guys on that. Okay. Now, the important thing, yes.
Nodes. Do we have to know like the other? Would they always say like um anterior and pectoral, or would they ever just say pectoral?
They might say anterior because that's the technical term for it, anterior node. Obviously, they could throw in pectoral. Whenever I've seen it, they've given both because SGU is pretty fair with their questions. In terms of central nodes, they're the same as central. No, they're not the same. The sentinel nodes are nodes that are considered the first point that you can analyze any sort of cancer development. Okay, sentinel is a generalized term. Sentinels, I like to think of people, sentinels are like back in the ancient days, like they used to monitor any sort of danger that's coming into the town. They were the sentinels of the town. That's why sentinel nodes are named for cancer first point of metastasis or movement into the lymphs. Okay. What is for cancer? Metastasis is associated with peristernal, especially if it's going to the opposite breast tissue, right? So if it's going from one breast tissue to the other, it's peristernal, okay? It may cross contralaterally. That's what they're trying to tell you here, okay? All righty. Let's do the abdomen. Quick thing, if they ever mention lymphedemiopathy, it's because patients have had all of their lymphatic nodes just destroyed. That is essentially not allowing for the lymph to drain back into the axillary node and eventually back into the superior vena cava, where all of the lymph material tends to go. Lymphedema is caused by the obstruction of this, right? There's no nodes for things to drain into. So the fluid just builds up like edema, right? This is an edematous state. Edema is just meaning extracellular fluid is just hanging out. It doesn't know where to go. And this is lymphedemiopathy, which is associated with lack of, typically with the lack of your draining lymph nodes. Okay. Abdominal, let's go over this because the abdomen is going to cover more so in your term 2, but there's a couple of good points to keep in mind. You guys are correct. Killing it. I love it. You guys are You guys are much better than how I was prepping for this exam. It's probably because you guys have an extra week. I'm not salty about that. Just kidding. 2/3 of the distance from the umbilical. What point is this, guys? McBurney's point, right? The famous one, McBurney. I like to think McBurney, like Bernie Sanders, brings the burn. So your appendix is about to explode, the burn. It's a dumb way of remembering it, but it works because it's 2/3 distance from the umbilicus, and it's located in this region. It's a great incision point back in the day when they used to do like actual surgical removal of for your appendectomy. Nowadays, they can go laparoscopically and not have too much kind of scarring of any kind. Obviously, you want to not like hit your inguinal nerve, but don't worry about it. Most of the times you won't get tested on that at all. Okay, this one kind of came up once or twice in a couple of modules, actually a couple of other previous terms in terms of the rectus sheath. Okay, your abs, something that is basically non-existent if you know, when you're like studying medicine because you're overworked and overstressed and you're like eating too much. It do be like that, but rectus sheath is involved with your abdominal muscles and how they get placed, right? Your abdominal muscles at the arcuate line, which is basically slightly below your umbilical point, right? Is that the fibers run at a different point versus when they run below the arcuate line. Okay, above the arcuate line, things cross over very simply, right? The external abdominal muscles go above it, right, over the rectus abdominis, right? The internal one gets split into two, right? And then finally, your transverse goes underneath, right? And then they form this linea alba, which is line of white. If you guys know your Latin and Greek, linea alba is right here. Now, the linea alba is same when you go below the arcuate line, but now everything goes above the abs, right? Over your rectus abdominal muscles, which are your ab muscles. They go above, and that's just a very simple concept. It's often something that trips up people based off of the internal oblique and how they test for it. But here, you just have to remember below the arcuate, everything goes above the ab muscles. Okay, I'm going to repeat that one more time. Abdominal muscles, right? If it's below the arcuate, everything goes above, right? Below the arcuate line, everything gets split into two, right? Especially your internal oblique muscles get split into two. Cool. Let's go over blood supply. This freaks out a lot of people, but it's fairly simple, right? You have your aortic arch, right? And your aortic arch gives off a bunch of branches. And you guys learned the early on branches that I mentioned to you guys, vitamin C and D. But when you guys get further on into your term here at SGU, there are different branch points that you're going to learn. Obviously, you don't have to learn all of them now, but you just need to know that there is two really important kind of branch points for the time being. The first one is the common iliac artery, which then gives off the internal and the external, right? Internal goes to the internal structures of your pelvic kind of cavity. Your external, guess what? It goes externally and goes to your limbs. Very simple concept, nothing too crazy about it. Now, in terms of venous drainage, it's very similar, right? Except now, instead of talking about the aorta, we're in the vena cava, right? Inferior vena cava, which is coming off of and creating the common iliac vein. And that's going to eventually become the inferior vena cava. And the inferior vena cava goes up, meets up with the superior vena cava, which is draining all of your upper limbs and goes back into your your right heart, and which then is going to get it into your pulmonary kind of circulation. And once pulmonary gets oxygenated, then it comes back to your left heart and then eventually gets ejected out into the aorta. Remember, it's a closed loop system. Nothing ever leaks out except for when you have some kind of pathological state. So just keep that in mind. You guys are going to be good on that. Let's do this question. Exactly, guys. This is the ascending lumbar region, right? Keep this in mind. This is it's a fundamental concept. So what are we talking about exactly? We're talking about your accessory hemiazygous, azygous veins, as well as your left ascending veins, as well as the left renal veins. So these are the ones that they like to test on. Remember specifically your azygous versus your hemiazygous. Those are associated with accessory pools of blood returning back to the heart, right? That is very important. These are alternative routes as compared to your vena cava, okay? Don't worry about it too much. They're going to cover the exact mechanism of it in term 2 of what happens, but they might have given you guys a general preview when you guys cover this in lecture. Let's do this question. Yep, you guys are killing it. Exactly. This is the genitofemoral, right? Now, this is really important, knowing the efferent limb versus the afferent, okay? Afferent is associated with the ilioinguinal nerve, right? That's at the L1 level, right? Whereas the genitofemoral branch is the efferent limb, and that is from your L1 and L2, okay? Critical that you guys know your cremaster reflex. I believe Dr. Rao should have taught you guys this, and he basically covers a lot of the abdominal innervation, or Dr. Rayburn should have taught you guys this. So keep this in mind. Know your genitofemoral, right? L1, L2 versus your ilioinguinal, which is associated with the afferent. Okay, here it is. This is what I mentioned to you guys right here. Keep that in mind and you should be good. Let's do the pelvic. This is important and it throws off a lot of people because it's sometimes a little too simple. Exactly. Perfectly done, guys. It is what? What are we talking about? Ooh, ooh. This is interesting. Okay. Okay, we got a little bit of mix of answers, but yes, you guys are correct. It is D, the majority of you guys. It's the transverse fascia. Okay, this is really important. I'm going to cover a nice mnemonic of keeping this straight. It's the transversalis fascia. Now, it's ice tie. Important that you guys know this. Remember, internal spermatic fascia, transverse fascia, right? They go together. If you put your ice tie together, they basically line up as like ICE and TIE. So each of them is associated with the other. Because remember, everything in terms of reproductive system, it started off in your abdomen. And as it descended downwards, it started penetrating through different levels of fascia and muscles and bones and etc. Right. And it finally got to the point where it created like the genital structures, right? Especially your reproductive organs, the testes and the ovaries. Obviously, the ovaries are still hanging out in the abdomen, but not too far down. In terms of lymphatic drainage, whenever they talk about the testes, what lymphatic drainage would it go to? It's the lumbar. That's also a great exam question that they like to ask about. So sticking to what we know with the spermatic cord layers and the derivatives, the internal spermatic fascia is a branch off of the transversalis fascia, right? We're talking about the abdominal cavity with the transversalis fascia. The cremaster muscle is actually a branch off of the internal oblique, right? Which makes sense because if it's an internal oblique and the innervation is coming from the lumbar region and the cremaster reflex is associated with it, you guys can make those connections together now. And then finally, the external spermatic fascia is associated with the external oblique, and voila. That's how you remember your ice tie. Let's do this question in terms of hernias. I'm going to tell you guys a fantastic way I remember it. Feel free to drop it in the chat also if you guys are kind of confused on it. Okay, we got a mix of answers with this. Understandable. The answer is indirect inguinal hernia. Now, why is this indirect inguinal hernia? Let's take a quick peek at this. So diagnosed with the inguinal hernia, right? It goes to the deep inguinal ring. That's also another kind of key giveaway, because remember, indirect actually goes through both the deep as well as the superficial ring. Now, I'll explain why in a minute. Versus your medial, it only goes through your superficial ring. That's a key detail that I want you guys to remember. The mnemonic that I use to remember my hernias correctly is MDs don't lie. Okay, if you guys remember that mnemonic, you guys can get a good chunk of these questions correct. MD stands for medial and direct, right? If it's medially located to the inferior epigastric vessels, that is your direct inguinal hernia, often associated with like lifting heavy stuff and strain. It can even happen from passing stool too. And indirect is associated with lie, like LI, so lateral indirect. Associate that. And this is very important. This is a key distinguishing factor. It is both deep and superficial, whereas the medial is only superficial. Okay, that is very important. Very, very important. And only the indirect often happens with a congenital system, right? The direct, I don't think typically happens in babies, but for always, I kept it kind of straight in terms of indirect versus direct. Indirect happens more so with babies. They haven't been lifting heavy things. It's not an indirect kind of insult to their system. Let's do this one. Guys are killing it. Awesome. Exactly. So this is really important. The patient comes in with a relaxin hormone. This is actually a hormone that's secreted by the actual umbilical kind of connection to the uterus. So that's something you guys are going to learn in term 2, but the relaxin hormone is very important because it basically softens a lot of the conjugation and the composition of the pelvic diameters, right? Once that softening happens, the baby's head can actually pass through the mother's pelvic canal, right? That's very critical. It's the true conjugate that will likely be unaffected in this case, because the true conjugate is very much different. And I'm sure I'll show you guys the picture of it, and that outlines all of it. Okay. The one that they often assess for whenever, if a mom can do a safe delivery, is of course the interspinous diameter, right? That is the most critical one that the baby's head has to pass through for a normal vaginal delivery. Whereas the other lines tend to remain fixed, because these lines, right? These lines are basically semi-useless because other organs are lying on top of it, such as the bladder, right? The bladder would be right here, and the diameter for this doesn't really change too much. So that's why when you guys saw the other one, the true conjugate was the one that you left alone. That's the one that isn't affected, right? Keep that in mind. The true conjugate is very, very much tested on this. Okay, I gave you guys another set of pictures to kind of test yourself on the knowledge. Just a quick thing, if you need to assess a patient, and if you just had their pelvis, which makes no sense if you're in the anatomy lab, if it forms like a V-shaped in terms of this is telling you like a female, versus if it's more narrowed, if it's a male. So that's the pubic arch, right? That's how you can tell a male versus female pelvis. Okay. Just a little bit of random information that I learned during office hours. Let's do this question. Awesome. Exactly. This is very, very heavily tested, especially in terms 1 in MSK and as well as term 2. Okay. It's the pubococcygeus muscle. Now, the pubococcygeus muscle, it's involved with a lot of things, but I'm going to kind of show you guys that the pubococcygeus muscles, as well as the puborectalis, as well as the iliococcygeal muscles, are all part of the levator ani muscles. These muscles basically are the ones that are involved with your external anal sphincter, right? It essentially holds the crap in, which for lack of better words is what I'm using, it's important that you guys remember that these three muscle groups always gets tested. So why isn't B also an answer? Because when you're thinking of B, iliococcygeal muscles, the pubococcygeus is the one that is closely associated with, like you see how the pubococcygeus is the most proximal thing to the anal canal. That's the one that's more heavily involved. The iliococcygeal is mostly a stabilizing muscle, right? It helps provide the pelvic floor that you're working with. That's why if it's a urinary incontinence, then it's going to be puborectalis. Pubococcygeus is fecal incontinence, okay? Just a bit of tidbit from yours truly. Okay, let's do this one. All right, you guys all know this, but I'm going to test your guys' knowledge a little further, okay? What nerve is messed up in the Trendelenburg test? Like, what's the nerve? Exactly, superior gluteal nerve. That is very, very important, guys, because they're not going to keep it this simple like you're seeing here. They're going to ask you second order, third order questions. Obviously, you guys are correct. Gluteus medius and the gluteus minimus on the right side, that is the one that's affected, right? If the left hip drops, it is the opposite hip that is not stabilizing it, right? That is what I want to make sure you guys learn with your Trendelenburg test, right? Look at this. The nerve paralysis or spastic kind of movement is the one that causes the foot drop, okay? It's not able to hold and balance your pelvic length, and that's going to cause the foot to drop and lose your stability. And like you guys said, absolutely superior gluteal nerve that goes and innervates the gluteus, I'm choking on my words, gluteus medius and gluteus minimus. What innervates the gluteus maximus? Exactly, inferior gluteal nerve. Now, everyone spends a huge chunk of their time at the gym, you know, lifting and doing everything to increase their gluteus maximus, but the gluteus maximus is only involved with one thing, which is just getting you standing from a seated position. That's the only thing that it essentially does. Everything else is done by the gluteus medius and minimus, and that's the one that's often ignored for a lot of people because those are deep-seated muscles that are basically stabilizing muscles of when you're walking versus when you're running, etc. And they can also lead to the Trendelenburg test that you're seeing here. Okay, let's talk about lower limbs. Hopefully we can wrap this up. Now, let's do this question. Exactly, guys. It is the ascending branch of the medial circumflex femoral, okay? Now, the circumflex femoral provides a rich anastomosing supply to your organs, right? Not to your organs, but to your lower limbs, as well as the femoral head. Now, since you're talking about a 72-year-old, can you guys tell me what happens if there's some kind of trauma to the femoral neck, but the baby it's happened to seems to still get blood supply to the lower limbs? Like what artery is providing blood supply? Collateral blood supply. This one's a tough one. Some say deep femoral, some say obturator. What is it, guys? Deep femoral? Obturator? What is it? It's the obturator, right? It's not your circumflex, because remember the baby has injury to the femoral head itself and the neck, but the obturator actually turns into it basically obliterates and turns to the obturator ligament, and that ligament is essentially useless. It just provides further stabilization. But when you're a little kid, it actually provides blood supply. There's a blood supply that's running through that area, and it can provide a little bit of collateral blood supply to the lower limb so that the baby can survive. Okay, keep that in mind. It's a bit of well, here, acetabular branch of the obturator. That's the one I want you guys to know that's associated with babies. Okay, keep that in mind, acetabular. All right, here's the important thing. This is pretty critical. This is the Shenton's line. This is the actual line that they often use if a lot of orthopedic surgeons often assess for in terms of like the angling of the actual femoral head. And if it's slightly more oblique or more acute, then they can potentially suggest a hip replacement. Okay, this is important. The acetabular fossa, right, is like right here. And the obturator and the branch of it, of the acetabular artery, goes right through here and provides blood supply collaterally. That's why your femoral neck, even if a baby like fractures or damages their femoral neck, they can still survive and retain their lower limbs in terms of blood supply because of that acetabular artery, right, coming off of the obturator. Okay, important. Okay, here's the fracture. This is at the neck. So good prognosis or poor prognosis? Poor, right? The patient, this is a primary weight bearing bone of your body, right? You shatter this, you shatter your ability to walk, right? That's why femoral heads have to be very strong. That's why the femur is one of the strongest bones in your body. It's also one of the places where not only bone deposition happens in a lot, but also red blood cells get made in the cortex of, the medulla of the actual bone. Okay. There you go, intercapsular fractures, right? These are bad. These are capsules. So this is the capsule that we're talking about. This is at the femoral neck. If it's below this, then the prognosis tends to be better, right? You don't have avascular necrosis because you haven't disrupted the blood supply. That it's like, with like lower portions. Anything with the subcapital, cervical, and then basocervical, those tend to be bad, right? Avascular necrosis, reticular arteries, and the head of the femur can kind of get disrupted. Okay. Now, which one is the one where it's flat on the top of the head again? Can you unmute and ask me that? I'm a little confused what the question was.
There's one that's like the femoral like head is like flat. Like there's some kind of clinical correlate for that. If not, I'll look at it and I'll put it in the chat.
Yeah, please do send it to everyone. I don't remember that particularly because we were more tested on the fact that there was a fracture, but please, I love any sort of information that you guys can share with each other.
Is she talking about avascular necrosis of the femoral head? Like, is that what that's referring to? Because that's what came to my mind first.
Yes, it is avascular, right? And if we have that avascular necrosis of the femoral head, you're not having further blood supply going to your lower portions of your lower limbs, right? It's not going to your feet essentially as much as it should. So you could essentially have necrosis to a much more of a degree with the femoral head kind of ruptures. Okay. Let's do the knee exam. Remember, the lateral femoral condyle to the anterior tibia is the ACL, right? The ACL drawer test is one that you guys should have covered in your OSCEs. And your medial femoral condyle to the posterior tibial is the PCL, right? The quick way to remember that is a LAMP. I used LAMP whenever I was thinking of any sort of injury to the ACL versus PCL because it kind of sometimes confuses folks where everything attaches to. Okay, let's do this question quickly regarding your physical exam. Exactly. Yep. You guys are killing it. Perfect. Exactly. This is the anterior drawer test. So the tibia can be placed slightly more anteriorly due to the fact that there's an ACL tear, right? Anterior drawer test, you got to know it cold. You will get images like this, okay? They won't label it. They won't show anything other than the fact that this line is disrupted. And that's how you tell if there's an ACL tear versus a PCL tear, okay? Keep this in mind. This is really important. Make sure you have this down cold, okay? Let's do this question. Okay, guys, unmute yourself. You guys know this very well. What is the unhappy triad?
So I remember it as mammal, so medial collateral, anterior cruciate, and then medial and lateral meniscus.
I love that. That's a fantastic mnemonic. Keep that in mind. It's MCL, ACL, medial meniscus, as well as lateral meniscus that can be affected. The unhappy triad essentially happens mostly in football, right? It's just a valgus pressure / trauma to the knee, right? It essentially snaps the knee, gust of wind in, right? And then that once that snapping happens, the medial MCL, MCL gets ruptured. Then once it snaps back in, then the ACL can be ruptured, and then the meniscus that are basically providing the structural kind of support underneath can also be torn because they're all displaced and moving both of those bones. Okay, both the femur as well as the tibia fibula. Okay. There you go. You guys are killing it. MCL, ACL, medial meniscus, lateral meniscus, so on and so forth. Okay. The most common is the medial collateral, right? Keep that in mind. They don't ask too much about the meniscus because you guys are going to learn that in multi-systems later on. But for now, just know anterior cruciate as well as the medial collateral. Okay. Bursitis. This is basically very, very buzzword heavy. The Baker cyst is the one that often throws a lot of people, and that happens posterior to the knee, right? Like it happens in the back. That's not something that you guys are going to be tested for now. That's something that's term 4 problem. But I want you guys to know your housemaid knee as well as clergyman knee very well. The housemaid spends a whole bunch of time on the floor trying to like clean the floor, mop the floor. And that's associated with the subcutaneous prepatellar bursa, right? That's like associated with the fact that you're leaning over and scrubbing the floor. That's right here, right? Versus the clergyman, it's the infra, right? Like think of like you going to church, praying at the altar. Like think about the way your knee is located and how much pressure you're putting on it in terms of weight bearing, okay? Let's do this question. Guys are killing it. Exactly. This is the lateral femoral circumflex. Okay. This is important to know in terms of what you need to associate with the radiological study shows a posterior dislocation of the supracondylar fracture, right? Remember, this is supracondylar fracture compressing the popliteal artery, right? Which of the following could provide adequate blood supply. This is what you need to know. Lateral femoral circumflex. Okay. Critical, critical, critical. Okay, these are the geniculate arteries, right? The nice thing is if they're geniculate and they're providing arteries from the popliteal, they're like providing ancillary blood supply. The two that are coming from the descending portion, right? One from the femoral artery and one from the lateral circumflex. This is the one that's providing collateral, right? Just in case if the popliteal gets shut down, this is providing still blood supply going to lower portions of your limb, okay? Important. I always learn this based off of functional anatomy versus this pure memorization because there's too many branching points and this is a very rich anastomosis point. So don't trip about knowing every single detail. Just know that the geniculates are all associated with the popliteal. The two exceptions to this, right, is of course the two that are coming from the geniculate artery, one from the femoral artery and then one from the lateral circumflex femoral. Okay, let's do this one. I'm going to tell you guys, whenever you guys are learning your compartments, learn them based off of SGU slides because they are very diligent about asking questions about the compartment level stuff. They don't care about you guys knowing the exact muscles of the lower limbs. They want you guys to know the compartments and how they move, okay? And you guys are killing it. Exactly. This is a dorsiflex everted foot because remember, the patient is admitted to emergency room surgeon analyzes it and has severed the tibial nerve, and what's providing innervation, like where does the tibial nerve go and innervate, and we're going to take a look at that, right? Which is specifically eversion that you're going to be seeing right above, right? Everted foot is coming because of the lateral compartment still working, right? Remember, our entire system runs off of like counterweights and weights, right? If the tibial artery is gone, right? Tibial nerve is gone, then this is basically shut down. Your posterior compartment is shut down. The only thing that can work is the dorsiflect component, right? As well as the eversion component, which is the lateral compartment versus the anterior compartment, right? They're both working together. That's because the posterior compartment has failed, right? Because of the gunshot wound. Let's do
Just
this
a quick
question.
question on that one. It said something about a tibial has severed the tibial nerve, and isn't the tibial nerve the plantar flex and inversion? So is it just the opposite is what's?
Yeah, it's the opposite. The opposite is what would be more predominating, and this is how they ask these questions, honestly. Such an injury would result in which of the following? That's because the dorsiflect and everted foot is what you would see when the patient comes in, right? The patient wouldn't be able to do the plantar flexion, right? They wouldn't be able to push their toes down into the ground, so keep that in mind. No, feel free to unmute, please. Just keep that in mind. I want you guys to make sure you guys know these based off of the pathological states, as well as what is going to be still working normally versus abnormally. Okay, let's do this one. Yeah, feel free to unmute, guys. Don't even worry. I prefer to answer these questions, especially directly if I can. Yep, this is the other way they can ask the exact same question. They're going to give you a presentation of what is like the fracture or anything that's happening. Like when the cast is removed, like you have pronounced foot drop. So foot drop is very buzzword heavy, and paresthesia and loss of sensation of the left foot, right? And then lateral leg. So what's likely messed up? It's the common fibular, right? And that's very important that you guys know that in terms of your compartments, okay? Nicely done, nicely done. Let's do this question. You guys are killing it. Yep. Yep. Yes, this is the tibialis posterior tendon. Now, the way I remembered it is Tom, Dick, and very, very nervous Harry, right? That's how I remember this entire posterior compartment, especially the deep muscles associated with them. So let's just take a look. So this is what I was telling you guys about. And I think they mentioned this even during lecture. I think Dr. Rayburn or whoever taught you guys went through this. So make sure you guys cover this very well. Keep that in mind and make sure you guys test yourself based off of the posterior compartments, okay? Let's do, oh, sorry, here. The medial tarsal tunnels and the things that go through them, here it is, okay? The foot isn't tested as heavily because they preferentially like to give you guys brachial plexus stuff, and it's a little bit more challenging because this one you guys can just memorize straight off the bat and get most of these answers. But there's a couple of questions that they do like about the lumbar sacral reticulopathy based off of dermatomal levels affected. It's like, let's say there's like, I don't know, L4, L5 disc protrusion, right? That's causing, there's a disc protrusion, and that causes what type of sensory loss? It can be due to which nerve getting affected. L5 is damaged, right? So then you can get the specific dermatome that's like a band-like pattern right here, right? So what can you not do? Dorsiflexion and difficulty heel walking, right? And they can test for all of this based off of the clinical vignette that they give you. Compartment syndrome. Yeah, go for it.
Sorry, can I ask a question? On the previous slide with the Mnemonic, yeah. Would they ever ask anything between the tibialis posterior and the flexor hallucis longus? Because I feel like how would you ask about one of the ones other than the vein or artery, I guess? Like, how would you ask about the longus?
They might ask about the longest by like your like only one foot having some issues with this. Oh, okay. Yeah, I'll try to go slightly slower because there's a lot of material. I want to make sure you guys get out on a reasonable time. I don't want you guys to be here for like 4 hours. But yes, it's going to be the longest. Specifically, whenever you're thinking of the longest here, associate that with your big toe. They might give you specific issues with that. Keep that in mind. Don't worry about it in terms of like, once again, the foot isn't highly tested. They just like very specific details from it. Most of the time, they prefer the arteries and the veins, like you mentioned, as well as the nerves, because those tend to be the ones that trip up students. Okay. Those are the specific details they want you to know. Let's do anterior compartment, or sorry, the compartment syndrome. That's associated with the 6 Ps. And most of the time you will see the vignette and you will know right off the bat. This is a very easy point that you can get. It's basically, there are thick fascias, right, that are in the lower limbs. More specifically, you can actually get compartment syndrome in a lot of places, but likely causes is a tibial fracture, right? The tibial fracture is just going to shoot out a whole bunch of blood, and the compartments are so thick that like the fascia is so thick and bundled that it can't immediately relieve the pressure. So what you have to do is essentially do an emergency kind of tear through the deep fascia so that you could drain the excess blood that's pooling. Because weirdly, as blood is pooling, right, in the compartments, it's causing avascular necrosis, right, to your foot. And that's, it seems kind of like counterintuitive to kind of think about it that way, but like an anterolateral incision has to be essentially used to decompress your deep fascias, right? As always, pain, paresthesia, pallor, paresis, pulselessness, and you will see this. Like, you'll see the pulselessness part and the picothermia, and you'll know right off the bat that you're working with the compartment syndrome. Okay. Now the bones, they don't teach it as heavily, but it's still good to know because remember, there's an entire medical field dedicated to just the foot. There is 7 tarsal bones, 5 metatarsals, and 14 phalanges, right? Obviously, very similar to what we were looking at with the hands, because remember, we used to be quadrupeds, where we'd walk on all 4 legs. Now we are bipedal in nature, so quadrupedal versus bipedal. So keep that in mind. All right. This is their favorite one in terms of rolling your ankle. Whenever you're thinking of rolling your ankle, what is the likely culprit, guys? What ligament? Anterior talofibular and calcaneofibular. Absolutely. That is important. You guys got to know that cold. It is the one that they love to ask about. That is the one that they're going to test. And that's the one I'm going to ask you guys about right now. Feel free to drop your answer in. Exactly. You guys are killing it. Exactly. So most commonly torn is the anterior talofibular, right? And the mnemonic that I remember that always comes to my mind is always tears first. So A for always is talking about the anterior, T for talo, and then F tears, right? Like tears and the fibular associated with first. So always tears first, anterior talofibular. The second most is the calcaneofibular. Keep that in mind. They like to ask questions about this. There it is in all of their glory, and voila. Here is the layers associated with this. Now, just like your lumbricals that you guys learned back in your upper arm, there's a similar process with this. Of course, what you do need to know is that anything highlighted in red is the one that's tested most often. It's innervated by the plantar nerve, right? Your laugh muscles, right? And if you guys outline this, these are associated with your abductor hallucis, flexor digitorum brevis, first lumbrical innervated by the plantar, and then the flexor hallucis brevis as well. Okay. pads like dorsal dorsal like pads and dabs, same thing again. Now, once you guys need to know the specific innervation, is this the plantar interossei, dorsal adductors, and then dabs are your dorsal interossei abductors, right? 4 dabs, 3 pads, okay? Varicose veins, the buzzword for this is failed pump, right? The failed pump and the appearance of like retrograde flow is just going to cause all these veins to basically pop out, right? And surgically, you can go in, it's not really surgically, you can even do it in outpatient. You can go and obliterate these varicose veins, and they're very superficial whenever you're thinking about it. And that's going to present, if you guys get to CPR, like you're going to see that varicose veins is a big problem in terms of cardiac issues as well, okay? Dermatomes. Dermatomes for the legs are not as important, but they're good to know regardless. Remember, it's 4, 5, and S1. Remember, it's always 3 for the limbs. So it's only like 3 kind of innervation points in terms of sensory levels. Everything else is superfluous. They don't like asking too many things about the lower dermatomal levels. So just feel free to review it. I told you guys that highly tested dermatomes are these. So this I would know cold, okay? Reflexes. This is important, okay? There's a song with this. Buckle my shoe, 1, 2, buckle my shoe, 2, 3, 4, kick the door, 5, 6, pick up sticks, 7, 8, lay them straight. Okay, that's just a quick way of remembering the reflexes. These are tested every term, all the way up to your end of your first year here at SGU. Know these very well. Let's do this question. Yep. You guys are killing it. This is the deep fibular perineal component. Remember, this is what type of numbness is along the adjacent to second toe? Which nerve is most likely injured? What are we likely thinking about? What's injured, guys? First and second toe, lateral aspect. Deep fibular, right? It's the deep fibular. In terms of dermatomal layers, what if I told you guys what's the dermatomal layer that needs to be assessed for here? I'm just testing your guys' knowledge on this. I said L4, right? L4 of your first and second toe. First and second toe is always going to be your big toe, and like the second to big toe. I don't know what you would call it, the second to big toe, but you guys are correct. This is the deep fibular, right? It's a second kind of web space right here. Once again, the innervation to this is the deep fibular, but the dermatomal layer is L4. Okay, got to know that one. Voila, here it is. Okay. Now, here is the full overlay of the entire nervous kind of breakdown of this lower limb portion. I want you guys to spend some time going through this, especially your lower limb plexuses, because those are not as highly tested as your brachial plexus, but they are sometimes thrown in there for good measure for knowing if you guys cumulatively reviewed your knowledge of this. Okay. Let's take another quick break before we wrap it up for the day. I have another like 100 or so slides to finish. Recording. Okay. Now let's do some limb development. This is probably the last couple of things that you guys covered. Moving away from the gross anatomy that gross both in the sense that yikes, this is a lot of material, gross also because like you covered a lot of muscle, bones, nerves, and tissues. So let's kind of cover the limb development portion. This is actually not too high yield, but there are a couple of questions we did get on this. Remember, the basic somites are given rise to sclerotomes, which is talking about sclera. I like to think about like sclerotomes associated with your vertebra and ribs. Your myotomes is very simple because it sounds like muscle. Myo, fibrils, like myotangles, like all those things, muscle related. Dermatome is talking about obviously connective tissue, dermis, right? So very, very straightforward, nothing too crazy. Let's talk about in terms of growth. The molecular signalers, you're going to spend some more time learning it later on. But for now, I want you guys to spend some time learning Sonic the Hedgehog and then your fibroblast growth factor. Those are the ones that were heavily tested for us. The Wnt isn't so much. So these are all just fundamental things. Most of the time, if something major goes wrong with any of these molecular signals, it causes a spontaneous abortion, right? It's kind of scary, but your body has good countermeasures for assessing things like this. Limb development, okay? Now, limb development happens early on, right? It's about week 4, right? The basic crude like limb buds appear, right? If you kind of watch evolution, it's what happens at an embryological level, right? Everything's basic, everything's like flaps and like panels and things like that could cause you basic movements to happen. But as you get further and further differentiated, it makes so much more profound sense why like you get finger and why you get webs and all these other things, because we used to be more involved in the water so we could move around faster. Now, what causes the webbing to disappear, guys? What molecular mechanism happens that causes the webbing to go bye-bye? Apoptosis. That's a fundamental concept. Know that. That's a cumulative FTM question right there. Let's do this question. You guys are killing it. Exactly. It is incomplete apoptosis of the tissues between the digital rays. This causes like what particular presentation? This is like syndactyly, right? Keep that in mind. Syndactyly, right? Webbing of the digits, failure of the webs to degenerate, and it causes the fusion. Now, are the bones separated here? Are the bones fused or separated? If it's cutaneous. Separated, right? The bones are fine. The problem is that apoptosis just didn't happen, right? That causes the epithelium to just basically dissolve. The osseous one is often associated with congenital malformations. Fusion of the bones tend to happen with this, and that notching is associated with osseous syndactyly. Keep that in mind. There is a distinguishing factor, okay? Important. Polydactyly is one extra, right? One or two extra. And it's typically inheritance pattern is dominant, right, in nature, so autosomal dominant. Club footing, you're going to learn club footing a lot more in terms of different disorders. For now, just know that it's associated with like more so common in males as compared to females, and typically the foot is medial and inverted. Okay, let's do this question. Awesome. You guys are doing fantastic. This is miromelia, right? If it's an abnormal limb development, it's miromelia. If it's completely absent, what type of amelia is this? Amelia, okay? That's how I remember it. Amelia, or the lack of amelia, right? So exactly, you guys are killing it. Remember, it's complete absence with amelia. Miromelia, there's partial absence or like a disruption. Let's do cleft hands and cleft foot. This is ectrodactyly. They can give you these terminologies. I want you guys to know this. Once again, it's the failure of development of one or more digital rays. Digital rays are talking about the development of fingers, right? Now, often they're called lobster clawing. Don't, you will never see this on an SGU exam because it would be politically incorrect, but it's important to know that the digits can be partial or completely fused. Amniotic band syndrome is tested heavily because it's actually not a malformation per se. It's just that the amniotic kind of components are wrapped around. It causes a constriction and an avascular event. And if it's not getting the proper growth factors, the limb just won't develop, right? Based off of the vasculature and everything. And it causes either a spontaneous abortion, or if it's severe enough, it just causes like a limb kind of like, or sorry, spontaneous abortion is the more severe presentation of it. You can also get amputations straight off the bat, right? Depending on the region. Nothing will be associated with this other than the fact that it's a pure constriction level avascular event. Vactural, this stands for vertebral defects, anal atresia, cardiac defects, tracheoesophageal fistulas, renal anomalies, and limb abnormalities. These are commonly clubbed together, and that's a syndrome by itself, right? They happen in tandem. It shows you like multiple genetic as well as environmental factors have shut this down and caused these X, Y, and Z defects to appear together, okay? Bones and cartilage, I believe you guys covered this week. Let's do this question. What type of scar do we have here, guys? Because I know you guys can identify the phases based off of the question stem, but what type of scar? Are we getting a fibrotic scar? Yes, there we go, fibrosis. Exactly. So this is a maturation phase. Keep in mind, this is one of the tail end. The critical things to note with this is that this concept is coming over and over again, right? It causes vasodilation, neutrophils and monocytes get into the actual tissue that you're working with, and it causes the elimination of any sort of like bacteria that you've picked up superficially. And also it starts laying down mesenchymal cells develop fibroblasts, right? The blasts, like remember when you guys are learning blast versus sites, your blasts are proliferating in active cells. Your sites are kind of like your retired cells that are just hanging out and providing restorative / maintenance care, right? Migratory phase is when the clot becomes a scab, right? The scab that you see, it's a kind of a soft scab at this point. Once it gets fully hardened, then it's a hard kind of scab. It's mostly consisted of granulation tissue that's like type 3 type of reticular tissue. And when you finally get full-blown maturation, it becomes collagen, right? That's like collagen, it gets put in if it's severe enough kind of scarring. So keep that in mind. Collagen is more organized and structured. But the thing is that if the scarring doesn't properly get maintained, it can cause what two disorders? Like what type of presentation can you have? You can either go into a keloid scar or a hypertrophic scar, right? That's because you have excess deposition of collagen or excess activity of your fibroblasts, right? That are right here. So that's how I like to remember this process. I don't like to spend too much time just memorizing random details. I associate with the clinical correlates. So let's look at the kind of the generational process of this. Remember, you have your isogenous groups, right? These are like the groups that hang out and they have type 6 collagen networks that are constantly maintaining their location. And as the capsular matrix kind of further develops, you can get particular type of presentation. I'm going to show you guys those more in detail, but the type of cartilage I want you guys to spend some time learning is the hyaline, okay? The buzzword for this is know that it's glass-like, right? Elastic, there's a bunch of fibrous composition, and then fibroblasts look like train cars, right? Like look at they're all lined up sequentially. This one, how they like asking questions about this is based off of regional location. What type of cartilage are you going to find in your ears? What type of cartilage are you going to find in between your intercalated discs? Like those are the type of questions that they can ask with this. So don't just look at the histo slides and just memorize them. Associate them with each clinical like location. and learn it that way. Okay, hyaline cartilage, okay. Remember, this is type 2 collagen, cartilage. That's how I remember cartilage, hyaline cartilage. Okay. If you guys haven't looked at the first aid mnemonic for this, type 1 is bone, because like BONE has the word one in it, type 1. Cartilage, how I spell it is cartilage, right? That's a terrible way of spelling, but it's cartilage, right? It's 2. So that's how I remember what type of thing makes up each location. 3 is retricular, then that's like tree, like retricular, that's type 3. And then 4 is like the last one, basement membrane. That's how I test myself constantly on this material. Okay. Remember, this is involved with both appositional/interstitial growth. When you're growing, like you're going through puberty, what type of growth is predominating? Appositional or interstitial? Put it in the chat. Both. It's both. Fun fact, it is both. Obviously, in terms of what gives you height is appositional growth. Like interstitial is just making things more dense, right? Interstitial, appositional, you're growing taller, okay? Remember, this does not easily degenerate. That's why it makes up a lot of component of your articulating surfaces. Obviously, it will age based off of calcification, right? Bone formation and calcification. Okay, types of growth seen is appositional, right? That's because of your chondrogenic cells. They're constantly laying down more and more. And then you eventually get ossification, right? That's later associated with, remember, your chondroblasts, and as they laying down like matrix, then they're eventually gonna have the deposition of calcium phosphate. That calcium phosphate is what makes up your bones. Okay, that's important to know. Only occurs in young cartilages in terms of interstitial. Oops, let me get my marker. Interstitial growth. But after that, it basically more does the appositional. Okay, hormones that regulate it. You guys know your growth hormones. You know your thyroxine that's associated with your thyroid, and then your testosterone. That's why men tend to have less likelihood of fractures and traumas, because their bones have high levels. I mean, there's increased bone deposition and cartilage deposition and less wear and tear. But obviously, if you do more sports and other stuff, the tear and wear that you're going to get is much more pronounced. Okay. Hydrocortisone and estradiol that is produced by females, and hydrocortisone is it's steroids that we give, corticosteroids that we give that essentially decrease your certain parts of your body's function. It helps suppress your immune system. There's a lot of different functions with corticosteroids, but for now, I want you guys just to know that hyaline cartilage is associated with all of your growth hormones, okay? Articular cartilage, I like to think of as articulating points. It does not have a perichondrium. This is a question that they asked us when we were going through our exam. Which cartilage does not have a perichondrium? And we were sitting there scratching our heads. It was articular cartilage. Remember, the perichondrium actually holds a lot of your chondroblasts, and the perichondrium eventually adds and allows for further growth. It's going to be mostly found in a lot of articulating points, but keep in mind it can wear down just like hyaline. Okay, that's why, like, you can get shearing of two of bones coming together, where the pelvic and the femoral point kind of meet and they shear against as the articular cartilage disappears. Remember, there's no appositional growth. You don't want appositional because why? You don't have a perichondrium, obviously, but it's also because you don't want more cartilage to be put in here so that it grows outward, right? You just want it to stay where it is and maintain its function. Elastic is found a lot more in particular locations, right? What you do need to know is that there's type 2 cartilage fibers and elastic fibers. Elastic fibers predominate. I want you guys to associate elastic fibers with elastic cartilage. It's very simple, and you should be good. Fibrocartilage, whenever you're going through this, know that fibrocartilage is associated predominantly with type 1, okay? Type 1 collagen, what did I tell you guys type 1 is? Typically bone, but it's important because the ossification isn't done yet. All righty. let's do this question. You guys are correct. What are we looking at here? Is this elastic? What type of cartilage is this? Elastic, exactly. Okay, this is elastic fibers in the matrix. Remember, don't get this twisted with your hyaline, although the hyaline, the key differentiating factor is the glassy-like appearance, right? Here you don't see that elastic fibers are likely highly dense in this matrix. Okay, once again, just throwing this back here. This kind of looks like glass. This is a carriage, and this is fibers. Let's do this one. Exactly. Do we have appositional growth in your articular cartilage? Perfect. No, right? We want it to stay where it is. We just want maintenance of that said cartilage. We just don't want it to grow outward. Okay. Exactly. Chondroblast in the perichondrium is the key differentiating factor. Chondroblasts in the isogenous group, that's associated with your interstitial growth. Okay. Keep that in mind. That is something that we were asked a question about. There you go. There's the information again, just to reinforce the concept. Okay. Now, which cells are more active, osteoblast or osteoclasts? That was a trick question, right? I did want to trick you guys. Osteoclasts and osteoblasts are constantly working, right? The thing that is actually downregulated and not working as much is the osteocytes, right? Don't get this twisted with osteocytes versus osteoclasts. Osteocytes is for maintenance of the bone tissue. Osteoclasts is for breaking down of the bone matrix. For example, when you guys covered cardiac physiology, which you guys haven't fully covered, but you guys learned it in terms of muscles like physiology, you guys remember that certain muscles and certain nodes and cardiac components involve using calcium, right? L-type calcium channels. Those are dependent on calcium. So your osteoclast, whenever it senses or whenever your body senses that it's in a low calcium state, it's going to activate your osteoclasts. What hormone activates osteoclast activity, guys? This is a good one. I don't know if you guys have covered hormones. Granulocytes? No, not granulocytes. PTH, absolutely. Parathyroid hormone. Okay, that's what I was looking for. Parathyroid hormone is going to increase the dissolving of your bones. And this is really important. This is associated with also with what else? Good, you guys covered it. I thought I was like confabulating for a hot second, but osteoclasts get activated by PTH. And if there's like a nutritional deficiency of calcium, remember PTH is going to take over. Remember your vitamin D pathways gets messed up. Your osteomalacia can happen with adults and rickets can happen with children. Okay, know this very well. This is a good multi-level question. Let's do a quick quiz. Okay, what is the first type of cells that you're looking at here? What are these cells? Osteoblasts. And what tells you, what's the distinguishing factor between osteoblasts versus osteoclasts? Cuboidal. Now, I always learned histology based off of form and function. Whenever you see something cuboidal or chunky or columnar, it's always tells you that it's more active. It's like cellularly, it's more active, right? Versus something that is more like squished or skinny or like squamous in nature, it has less secretory function. So what do you think number 3 is? Osteocytes, okay? Osteocytes is very important, okay? And they're in their little lacunars, right? So that's where like bone depositions already happened. So they're hanging out in their little lacunas, hanging out, doing their thing, right? Just bone maintenance. What are these? the last of the big ones to cover. Exactly, multinucleated. You guys said it. So you guys see the little nuclei that are here. There's too many of them. And you're like, why do they have so many nuclei? Why are they hogging all the nuclei? It's because they have embryological origin very similar to macrophages. So they're multinucleated, they have multi-compositional shape, and they help break apart a lot of these things. Okay. Told you guys, macrophages located in the endosteum, right? Very important to know that. Summary, right, given to you guys. You guys can take a peek at this on your own time. This is important, but I gave you guys the fundamentals of what you needed to know. What we were tested on was in terms of the intermembranous formation, right? Spongy bone, right, develops via the bony trabeculae joining together, right? The periosteum forms the surrounding mesenchymal cells, right? Numerous ossification happens to form one solid bone. And then finally, this is often seen in your flat bones, right? This is important. It's in the flat bones, not anywhere else. Whereas endosteal, endochondrial kind of bone formation is associated with bone development. If you guys watch Dr. House, he was able to diagnose a patient because he saw an epiphyseal plate. That tells you that you haven't finished puberty, and that these plates essentially allow for further growth of your long bones. Okay, so obviously you guys know your diaphysis, right? Your diaphysis is basically the body of the bone, whereas the epiphyseal, right, versus epiphyseals are located more close to the shaft or to the tail ends of each of the bones. The shaft is actually the body. Okay, my bad. So there are 3 zones. Okay, what if I told you guys the question of when you're looking at the epiphyseal plate, the plate looks like stacked coins. What region are you guys in? Stack of coins. Proliferative. Okay, important to know that. Important to know that. Okay, whenever you guys get questions on these, base it off of the regions and what you're seeing there. The zone of reserve cartilage, right? That is basically just serves as a zone where you can have like reserve amount of cartilage essentially. And what gets tested more heavily is the zone of proliferation and the zone of hypertrophy. Okay, they don't ask questions too much about everything else, right? Because remember, this is growth that's happening this way. Okay, this is the shaft right here, and then this is the end plate right here, which is the epiphyseal plate. Okay, just know that, and you should be good. Hypertrophy, look at all the chunky cells. They will give you a histological image of this, and they love asking questions about this. Okay. Now, the 2 things I want you guys to know is that when you have this, there are kind of different components of the bone and the way that they're shaped. Okay, obviously the fundamental unit of any bone is an osteon, right? Osteo sounds like, you can make the correlate of osteo sounds like bone, right? But what they do ask about is interstitial lamellase. These, okay, these are parts where bone remodeling has happened, and the osteon is partially dissolved or like rewritten over, right? Because remember, you're getting a constant deposition of calcium and then a constant deterioration of stuff in order to maintain your blood calcium levels. They do ask questions about Volkmann canal, know that very well as the Havesian canal, because those are the 2 that they like to ask about in terms of questions wise. Okay. All right, this, I swear to you, this exact image came up at least 3 terms worth of exams. So know each of these Roman numerals very well. So let's just quickly go over it. 1 is your circumferential lamellae, right? That's this whole chunky bit, right? Now, your osteon, or 1 functional unit, is this, right? Number 2. Your Havesian canal is right here. So those are the canal that has vasculature going through it, right? And then finally, we get to the interstitial lamellase. That's your 4. That's where bone remodeling has already happened. That's like in between, right? And then finally, Volkmann canal is associated with 5. That's right here, and that's cross-connecting 2 Havesian canals. Okay. Here's another picture, further zoomed in. Remember, these are your canaliculi. What type of cells are hanging out here? Put it in the chat. Osteocytes, right? Because remember, osteoblasts are big chunky cells. Here, it's going to be more so of your osteoclasts. Okay, they've done their work. Now they're just doing bone maintenance. Let's do this question. Yep, you guys are getting it exactly. These are osteoblasts. So remember, involved in bone matrix deposition, as well as differentiating eventually into osteoclasts. Exactly, nicely done. You guys are killing it. Let's do this question. Exactly. So the important thing to note is that this is a classic presentation of osteoarthritis, right? It's inflammation of osteoarthritis. So like osteo meaning bone, arthritis meaning the joints involved with this. So whenever you think of osteoarthritis, I want you guys to remember of your DIP, okay? What does DIP stand for again? Make sure you guys, I'm just testing your guys' anatomy knowledge. Distal interphalangeal joints. Absolutely important to know. Make sure you guys make those jumps because they can give you DIP versus anything else. Okay, there you go. This is most common. Why is it most common in postmenopausal women, guys? What hormone is downregulated? Low estrogen, right? Often it's done, a lot of women actually go on hormone replacement therapy. So they might get exogenous, they might even get birth control pills, which have high levels of estrogen. And you're going to cover that in term 2, but it's one of the ways we can potentially, as an adjunct, treat for the osteoarthritis. Okay. There you go. And remember, one of the downregulators of osteoclast activity is estrogen. Now, here's a second order question, guys. What actually controls osteoclast activity? Is it the hormones directly or via some other cell? Do osteoclasts directly respond to hormones? Is the question at hand. Via osteoblast, exactly. So you guys are saying it. It's important that you guys know that the parathyroid hormone and any other hormone goes directly and works at the osteoblast level, and then they have releasing factors that they go and regulate with the osteoclast activity that can either upregulate or downregulate the activity of the osteoclasts. Okay, really important to know that bit. Let's do this question. Exactly. So you guys are seeing that this bone is just falling apart. So postmenopausal woman, right? You're going to have increased activity or decreased activity of osteoclasts. Increased activity. Nicely done. They can ask these questions multiple ways. So make sure you guys stay aware of that. Let's do this question. What is the zone of hypertrophy, guys? Told you guys they love asking these questions. Okay, we got some C, we got some B. This is an interesting distribution. It's actually C, okay? Keep that in mind. This is how they like to ask. It can be quite trippy in nature. So this is the zone of proliferation. That's why you're seeing a whole bunch of it. This is the zone of hypertrophy. You guys see how the cells have kind of elongated, right? Okay. Let's do, or there it is, proliferation, hypertrophy. 4 is calcification, 5 is ossification. Proliferation, buzzword, stack of coins. Gotta know that cold. And if you guys had a little bit of confusion versus the epiphysis versus diaphysis, the shaft is associated this way. And what do you guys think the growth is going to be? Is it going to be moving towards the end of the bone, towards the shaft? Hint, hint. Towards the shaft, exactly, right? Remember, you got to calcify. So, so you got to take these cartilaginous matrix that you've created and you got to add calcification factors to them. So that's the fundamental concept. That's how you have long bone development. Let's do this question. You guys are killing it. I really am jealous of your guys' extra week of material because or extra week of reviews that you guys can do. And because, oof, you guys are going to do amazing. Okay. So the answer here is B. You guys are doing fantastic. It's chondrocytes in the proliferating zone of the growth plate. That's important. Got to know this one, guys. It's undergoing mitosis, right? Proliferation, zone of proliferation. Here it is. Once again, stacked coins is the buzzword for proliferation. Let's do this one. Quick question on bone repair. Now, this one is really hard because remember, it's not like your soft callus versus hard callus that's happening at the bone level. In your skin level, it's just basic. It's straightforward. You just form a granulation tissue and it heals and it forms collagen. But here, in terms of bone repair, there's soft as well as hard in terms of calluses that can form. What can soft calluses cause a secondary bone breakage, or can the hard calluses? I want you guys to think ahead of this material. Don't just make it a memorization game. It's actually soft. You can re-break your bones in soft callus because you haven't laid down the sufficient bone matrix that you need, and it hasn't properly ossified. A hard callus is sufficiently ossified enough that it wouldn't likely break again. Okay, so we're going to go through that quickly, but you guys are correct. The answer is A. Let's take a peek at this. Okay, first thing, you have a shaft breakage, right, of your bones, and that causes what? A whole bunch of blood to basically drop in. That can cause macrophages and neutrophils to come into the site. Then you get fibroblastic growth, and then that allows for what type of tissue to be laid down, guys? What type of collagen? Not yet, not type 1 yet. Remember, type 1 is bone already. It's actually type 3 first, and then it's going to become type 1. Okay. So that's just a little bit of interesting information. It's not something you can be tested too much on. So keep that in mind. First thing you need to know is that the fracture is going to have an intermembranous ossification by osteoblasts, right? That's going to lay down these via the fibrocartilage architecture that you've laid down. You can then throw in the ossification component, right? So this is intermembranous ossification. This is new bone. It's a compact bone. This is a hard callus, okay? It can't really get more trauma at this point, whereas a soft callus can easily just go right through because it doesn't have a really strong structural support, okay? Let's do this question. Oh, I had a question regarding going back to the first one, why it's not C. It's not loose connective tissue and fibroblasts and vascular endothelial cells. That would happen much later because the fibroblasts are there, but already you've formed partially a soft callus. So the vascular endothelia and loose connective tissues aren't the ones. Like loose connective tissue wouldn't be there. It's like that's why I'm saying like it's a very particular detail with the soft callus to know that a fibrocartilaginous architecture is already set in place, right? It's not loose connective tissue for the person who asked about why it's not question C. You guys are killing it. Sorry for jumping around a bit. The answer to this one is absolutely A. Now, what are we talking about? Is this vitamin D synthesis? Please tell me yes. Yes, okay. This is important. If I told you guys it's one hydroxylase that's messed up, where are we talking about? Is it in the kidneys or in the liver? Kidneys, right? If you have tubular or kidney failure that's happening, the patient can actually present with low levels of calcium, right? Because what can they not create? They can't create 1,25 dihydroxycholecalciferol, right? That's the active form of vitamin D. So important to know that. You guys are absolutely correct. It is A. Remember, this active form can then be brought in, right? Remember, it's a cholesterol, so it can quickly diffuse through. It's a lipid soluble thing. These are steroid hormones. It can go in and upregulate calbindin. Calbindin takes calcium and binds it and brings it in. That's how I remember calbindin. Okay, important to know that, especially in your GIT component of bringing calcium in. Exactly as I mentioned here, vitamin D, very important. Now, can we use calcium that is what type of calcium can we use? Can we use ionized calcium or can we use phosphated calcium to keep your heart going? Ionized, okay? The biologically active component is ionized. For bone deposition, it's calcium phosphate, right? That's why the combination of calcium and phosphate stabilizes the calcium ions further. So that's why it's important to remember that ionized is very, very important for keeping your heart pumping. And that's why we tightly regulate calcium levels. Okay, let's do a little bit of genetics. I believe this is getting to the tail end of our section. I do have one more section to cover with you guys. Let's do this one, quick one to test your guys' cumulative knowledge. Answer to this, guys. Exactly. So what is the diagnosis, young doctors? Exactly. Important that you guys know that this is achondroplasia. Please don't call people dwarfs. This is not, you don't want to call them that. It's bad. Pigeon chesting is associated with Marfan's, right? Brittle bones is osteogenesis imperfecta, right? And then cardiac abnormalities that can see with a lot of different things, even Down syndrome and even DiGeorge's. And then mental developmental disorders is associated with many causes. But what are the two gain of function mutations? Put in the chat. This is Dr. Sobering's lectures. I don't know if you've had Dr. Sobering, but he's a fantastic professor. Yes, it is Huntington and achondroplasia. Need to know this, okay? Very, very important. Another one is spinocerebellar diseases. Gotta know that one too. It's very similar in terms of presentation to Huntington's, but don't get those twisted, okay? Let's do this one. COL1A1 gene is all you essentially need to know for this one. Exactly. Okay, this is how they like to ask these questions, right? It gives you the clinical vignette, and then you can build your symptomology from there. Okay, exactly. This is osteogenesis imperfecta. If you see any one of these things, it's going to give you short limb kind of presentation of osteogenesis imperfecta. The short limbs is like hallmark. Obviously, they can also present with blue sclera, right? Hearing loss, short stature, respiratory issues, and disorder of the tooth, right? Let's do this one. This one often tricks up people, so know this one, very, very important. Yep. You guys are saying it. Yep. Okay. It is dominant negative. Okay. Which type of osteogenesis imperfecta is worse? Type 1 or type 2? Type 2, right? Because type 2 messes with the normal collagen and matrix that you've laid down, right? It basically twists the collagen kind of composition of even the regular ones. So that's why the dominant negative is very, 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 very detrimental to the patient's well-being. Okay. Whereas type 1 isn't too bad. They just have like low levels of it. Okay. Type 1 just creates the misfoldings that can mess around even with the regular ones. Okay. Here it is in terms of presentation, right? It's often lethal, right? And then type 1 typically has the blue sclera, buzzword heavy. Okay. Here's me kind of going over it again just to put it into memory. Type 2 is severe, very severe. It messes with the regular stuff as well. Okay, you guys can read that and further edify yourself on the process. Obviously, you guys know this very well because you guys covered it in FTM. Missense, right, might lead to a protein that's residual activity. Nonsense is an early stop codon. So just keep that in mind. Play around with your knowledge, right? These can be bad. Let's do this question. Based off of this, young doctors, what is the diagnosis? DMD, right? So is it a good prognosis or a bad prognosis? Bad prognosis, right? The thing is, Duchenne muscular dystrophy is it's more severe, right? Becker's is better. B, right? How I remember it is B in Becker's stands for better. D in Duchenne stands for death, right? That's how I remember it. Frame shift mutation for this. So keep that in mind and it'll help you guys a lot. So complete absence in Duchenne's, Becker's, there's some amount of it, of dystrophin gene protein, because remember, these serve as scaffold for your muscles. So don't spend too much time on this. You're going to learn more about it later on, but it's just important to know. Let's do this one. Fun fact, we actually learned about this again in term 4. It's really important. So patient gets a dose of codeine, right? And experiences very short, like very fast onset experience of codeine over usage, right? And you're like, what the heck happened? It's because the patient has a polymorphism. Polymorphisms are essentially unique variations between people, right? Especially individuals. Some of them tend to be fast metabolizers, such as ultra metabolizers, and some of them are poor metabolizers. So for poor metabolizers, you would give them a higher dosage, right? For ultra metabolizers, you want to give them a much lower dosage than what is to put it in therapeutical standards, right? So that's important to know. Here are the other kind of components, right? TPMT, you're going to learn about again, but it's dealing with your thiopurine drug, and that's specifically used for leukemia. And you guys, I believe, covered it in FTM as well. And if you give patients succinylcholine, I'm pretty sure you guys remember your FTM knowledge, that can cause malignant hyperthermia. What's a drug that you can use to reverse malignant hyperthermia? Dantrolene, absolutely. You guys are killing it. Okay. Per metabolizers, you got to remember, like for metoprolol, you might have to give them a higher dosage of beta blockers. Okay. You guys are doing fantastic. And then Fragile X syndrome, that's a triplet repeat disorder. Okay. Nicely done. Here is the slides kind of showing this again. Keep this in mind in terms of your ultra metabolizers, what you would give, right? Your standard dose of metoprolol, right, is inactivated. So the patient has too much of it. So versus ultra metabolizers, metabolize quickly and deactivated by CYPD 6. Let's do this one. What's the diagnosis, young doctors? Put it in the chat. Yep. You guys are doing it. I love it. Okay. The caudate nucleus, you're going to spend some time learning about this in term 2. For now, I just want you guys to associate this with Huntington's chorea. Okay. It's a very important thing. It messes with the basal ganglia, but the more specific thing that they like to ask about is a caudate nucleus. Know that it's very high yield and you're going to get those points. Okay. Atrophy of the caudate nucleus messes around with even the basal ganglia and the cortex, right? I was just teaching this to my term 2 folks. Okay. Triplet repeat disorders, know these. They come back as your cumulative questions. CGG, GAA, CAG. I like to think in Huntington's disease, you're in a cage, like your mind is in a cage of itself. And then finally, CTG is your myotonic dystrophy. Okay. Muscle physiology, I believe this is the last component I'm running through with you guys. Okay, let's do this question. Okay, so what's the drug for this, guys? You guys already know your sodium is the correct answer, but what's the drug? Get your FTM cumulative questions in there. Pyridostigmine, neostigmine, both work, fantastically done. You guys don't need to know too much in depth, but I just wanted to give you guys that cumulative set of knowledge. So you guys know this. It's once again, you're depolarizing the cell, and then eventually it's going to cause muscle contraction via, sodium, calcium kind of release too. So keep that in mind. You guys are doing fantastic with the myasthenia gravis component. Let's do this question. What's the toxin, guys? Make it third order with this. Yep, you guys are correct. It's latrotoxin, okay? It's going to have similar presentation to Lambert-Eaton, okay, which is a it's a neuromuscular disorder as well as a muscular degenerative condition. You're going to learn more about that in subsequent terms. For now, just for the time being, just learn it as it's going to be associated with increased presynaptic calcium concentration, right? It opens these presynaptic channels. It causes excess acetylcholine release. So if you have excess acetylcholine release, guess what? You're getting overstimulation. It's going to lead to a lot of kind of more upregulated activity like muscle pain, paresthesias in her legs. Okay. Nicely done, guys. Nicely done. Let's do this one. This is Dr. Toledo's material. I'm pretty sure you guys went to his office hours and he grilled you guys on it like fantastically, but it's important that you guys learn it very well. Yes, it is D. It's the shortening of the velocity and based off of the load, right? It's very quick in terms of what's produced. So keep this in mind. Don't need to spend too much time going over this because they're going to cover a lot more of this in CPR. But for the time being, just a little bit of fundamental knowledge to get you guys started, right? This is based off of the preload, afterload principle, which you guys are going to spend uber amounts of time in cardiac physiology going over it. As you increase preload, the force of contraction will also subsequently go up, right? So the velocity of contraction. So remember the curve shifts based off of increased preload to the right. So keep in mind. Let's do this. This is a quick first level question, but it's important. Yep. You guys are getting it. This is the shortening part seen. Okay, which of the following does not change? It's the what band? It is the A band. The A band stays the same. It's like the A team. The A team never changes. Everything else does change in length, especially during a contraction, right? So sarcomeres shorten, H zone shortens, I band shortens, A band stays the same, okay? And you guys remember it, you covered this, I think even in FTM, so just make sure you guys review those cumulative concepts. Let's do this one, a quick throwback question as well. Yep. You guys are correct. It's calmodulin, right? It's calmodulin. What you need to know with calmodulin, what type of thing that sets this off? Is it calcium? What is it? Calcium, exactly. So it's cross bridging that happens, right? Remember, this is smooth muscle and it's calcium driven. Once again, so conduction systems often rely on both sodium and calcium. Smooth muscles often just end up on calmodulin calcium complexes to get their muscle contractions, right? So that's what I kind of covered here. This is the whole myosin I, right? And the contraction. So keep that in mind. Let's do this one. Yep. You guys are getting this. This is a little difficult, but you guys we're at the tail end. Yes, the action potential duration to the twitch duration is much less in the skeletal muscle, right? That's why you really don't get cramps in your cardiac muscles, right? Like there's no cramping of your cardiac muscles. You can get avascular events, you can get strokes, sorry, not strokes. You can get MIs. A whole bunch of other things, but you don't get cramping of your cardiac muscles. It's due to the fact that the action potential duration to the twitch duration is much less, right, in skeletal muscles. Let's look at what is happening generally. Remember, ATP in this case is binding to it and releasing it, okay? What happens when you die in terms of rigor mortis is that there's no more ATP generated, right? Your cells aren't working. You've essentially expired. So it stays in a permanently fixated position because there's no ATP generated to unbind it from the troponin myosin kind of cross bridging, right? The actin myosin cross bridging. My apologies. Okay, so keep that in mind. Make sure you guys review that. And here is the unique properties of each of the skeletal, cardiac, and smooth muscle. So remember, troponin is involved with 2 of them, and calmodulin is associated with 1 of them. Okay, and you guys can run through this, but most of the time, you just need to know that cardiac, it's L-type calcium channels, and that's really important. L-type calcium channels are actually spent. We spend a lot of time learning them over and over again because a lot of drugs that we can prescribe to patients act on these directly. And then finally, let's do, I think this is the last question. Yes, I believe so. I basically kind of gave away this answer. Shame on me. So it is decreased decreased ATP levels, and that causes rigor mortis in skeleton. They might actually give you the image that I showed you guys above and ask you 1, 2, 3, and 4, which one is the one that's causing the rigor mortis, and what you should pick is the one that's subsequently showing that there's no ATP binding. Okay. Alrighty. And that wraps it up. And this is what I was telling you guys about, like the calcium channels. I just threw this in so that you guys can associate it with the appropriate things. Okay. Alrighty. Thanks, guys. That is it. I threw in some external resources that you guys can use. And these are associated with the cardiac as well as some of your MSK knowledge. So feel free to use it. These are links that go directly out to where you need to go and look at external videos. Okay. Alrighty, let me stop sharing and have a wonderful rest of the day. I'll stay for another minute or so because I have to run to lunch.
Thank you for this, but quick question.